Good evening, ladies and gentlemen, colleagues and friends. Welcome to another webinar session with the Sydney Prosthodontic Group. Joining me this evening are my colleagues, starting from my left, Dr. Thao Truong and Dr. Zoe Potres. Thank you for joining us, guys. And thank you so much for tuning in to tonight's live and interactive session. So if you have any questions, please do feel free to just scroll down to the bottom of your screen and key in your question, and I'll try my very best to deflect all the difficult questions to the rest of the panel. But as always, there's a large number of questions, so we'll try to stay on point that's relevant to this evening's topic, which is on improving surgical outcomes. A few disclaimers before we move on. Firstly, this webinar is sponsored by our sponsors, but none of neither me or the rest of the panel here have received any financial gain regarding whether it's products, monetary, or services. The information presented in this webinar is purely of our personal opinion, so please do exercise discretion on how you are applying these information to your patients. Like I mentioned, these webinars will not be possible without our proud sponsors. Firstly, starting off by Noble Bowel Care. For the ones that know me, that Noble Bowel Care has been sponsoring these sessions for many years. And again, this year there's no exception. They once again very generously sponsoring for the IT cost involved of running these seminars. We do have a Noble Bowel Care implant mentorship program starting in 2024. In fact, this week later on. So for the ones that's still interested to really further your education in dental implant, there's still a few spots available. So feel free to take a screenshot of this QR code or use this particular QR code to obtain more information about the course. But otherwise, the course it's separated into 4 modules throughout this year. Module 1 is on treatment planning. Module 2 is on implant surgery. The third module is regarding prosthetics, and last but not the least, a more full arch or more complex type of cases. So we'll take you through from the beginning of planning all the way to a more complicated case, with plenty of hands-on sessions and mentorship throughout the program. Our second sponsor for this evening is by Dyneck, who is a specialist in making sutures for the medical industry since the 70s. And a large number of sutures, I should say all the sutures that we're currently using at the practice is actually purchased from Dyneck. And personally, I just find they do have a huge range of sutures to choose from. There is pretty much a suture for every situation that you can think of, with excellent pricing. So for our audience this evening, there is a 15% off on any orders that you make with Dyneck up until the 31st of March. All you have to do is to mention that you have watched this webinar. For the audience that's tuning in for the first time or don't know much about the Sydney Prosthodontic Group, we are a specialist group, also sharing our offices with a team of endodontists and periodontists. So within our prosthodontic group, we have a number of clinicians offering you a full range of surgical and restorative services. In recent times, Dr. Garda Solomon, prosthodontist, and oral surgeon Dr. Thao Truong has officially joined the practice, further expanding our range of services to you and your patients. And our main aim is to try to, at the moment anyway, is to try to reduce the waiting list that's there. And I think we have reasonably successfully in doing so, dropping it down from a few months to sometimes just a simple matter of a week or so, which is not bad effort by the entire team. Our main mission at Sydney Prosthodontic Group is to establish meaningful relationships with you. So that's why for any and every new referring dentist, it is my obligation to call you in person to establish that direct line of communication and also because we do want to get to know you and we'll want to help you and your patients. And these sessions of webinars is merely our way of saying thank you for trusting us to look after your patients, and we're simply sharing what we've learned, the mistakes that we've made, and hopefully a few pearls of wisdom along the lines, simply based on the referrals that we've been received. So thank you so much for trusting us to look after your patients. We do not take that lightly, and we do work very hard to achieve the highest level of satisfaction for both you and your patients. So if there are any issues, any concerns, please do not hesitate to reach out, whether it's towards the practice or to me personally, and I will do my very best to resolve whatever issues that there could be. These webinars are also recorded, so if you want to watch previous webinars, just simply go to our website, the one on the red HTML address on the top of the screen, sitpg.com.au/resources. It'll give you a drop-down screen of all the previous webinars that Brett has very kindly saved and uploaded, so you can watch these on demand. So without any further ado, let's move on to the webinar, to the topic at hand of improving surgical outcomes. Personally, when I recall coming through uni as an undergrad, our tutors did give us quite a range of extractions to do, but surgical extraction, particularly the ones involving sectioning teeth or removal of bone, generally speaking, those are quite few and far in between, if you even had an opportunity at all in doing that, and definitely not wisdom tooth extraction or implant surgery. Whereas when you graduate, all of a sudden you're being presented with a lot of these more complicated cases. So, and whenever a complication do occur when it comes to surgery, it is so
distressing,
very stressful for both the clinician and the patient.
Yes.
And that's why I thought this topic might be quite interesting, is for us to explore, again, a vast range of topics with the aim to helping our audience and ourselves to how to systematically work up a case, diagnose, assess the patient, enable to lower the risk, and therefore that hopefully during treatment and after treatment, your complications are as low as possible. And as always, it's we never have enough time to discuss such a broad range of topics, so our apologies in advance if there are certain key areas that you felt it is really important, but we simply did not have a lot of time to go into it in detail. But we'll try our very best to cover as much as humanly possible, ranging from patient assessment, both in terms of medical conditions, medications, to extractions, whether it's a simple or more difficult extractions, minimally invasive extractions, wisdom teeth extractions, a little bit on implant surgery. So there's a little bit of there for hopefully for everyone as we move on. So starting from when you first have a patient walking through the door, we all ask our patient to fill out some sort of a new patient form, which includes the medical history. And I'm sure everyone's forms and medical history forms are a little bit different from one another, some with greater focus in particular aspects. So of course I won't go into detail of what your medical history form would look like, because you would simply know your cohort and the type of procedures that you do much better than I do. But I think irrespective of what is involved in that medical history form, I think ultimately our aim is to ask a few questions. Firstly, what medical complications could occur during surgery once you finished reading that form and discussing with the patient? And number two, how can it make it as safe as possible for the patient? And then finally, last but not the least, then you have to ask yourself the hard question, which is, can I safely treat that particular patient? There's many different ways of assessing medical risk, one of which you could consider to use is by using the American Society of Anesthesiologists classification, or the ASA classification. It can vary. Some of the classifications only goes to 4 levels, some goes to 6 levels. But irrespective whether it's 4 or 6, it doesn't really matter. The concept is the same, that level 1 means a patient who's reasonably healthy, whereas a number 5 or 6 is someone who's quite morbid, that you have to sort of really ask yourself twice before whether you should carry out an elective procedures on those patients, and you can read more about how this classification system works. But one very interesting question I've learned over the years to ask the patient is simply say, Mrs. Jones, how do you find with climbing up one full flight of stairs, let's say to go from level 1 of a building to a level 2 of a building? You know, for example, would you make it in one go without feeling there's a huff and a puff? And if you did made it to the top, that you're probably a level 1 or 2, as in medically they're reasonably fit for you to carry out a routine elective procedure, as opposed to, say, they said, oh, I think halfway through I might just need a moment to catch my breath. They're probably in that level 3 or even potentially 4 category. And if the ones that says, oh, forget it, there's no way I can make it up that flight of stairs without dying, then again, that is probably not the patient that you want to treat just yet. So that's a very simple way of working out a patient's physiology, because ultimately when we carry out surgery, sometimes complex procedures for patients, we're putting their body under a lot of physiological stress. And what you're really sort of trying to ask here is how does a patient's body react towards a very simple physiological stress? And then once you sort of have some idea of the patient's medical background, their sort of general fitness / medical level, there's a huge number of other factors that you may want to consider, including what is the complexity or the morbidity of the procedure. I said, how much trauma do you think you're really going to cause? And also, what is the length of the procedure? It's very different doing a half an hour, 45-minute procedure versus a 3 or 4 hour procedure, because the amount of bleeding the patient goes through, the amount of local anesthetic you got to use, and the whole lot of other systemic stresses that we're going to put on the patient's body, it really goes up exponentially over time. Of course, the skill of the surgeon, the skill of the anesthetist, if there is an anesthetist involved, and also the rest of our team, whether it's during that surgical management or even post-op care. The better is your entire surgical team with you, then of course maybe you're able to tackle a slightly more complicated procedure in a more predictable manner. So really look into a lot of different factors before you would decide whether a procedure is potentially safe or not for a patient. There's way too many medical conditions for us to mention in the short sort of 15 to 20-minute sections that I have on this particular aspect. But I think one general realm that I consider or think about is what is the healing potential of the patient, or are there any medical conditions or medications, etc., that may reduce the healing potential for the patient? Because every time you do surgery, they have to heal, whether it's angiogenesis, whether it's clotting, whether it's regeneration, whether it's removal of bacteria to reduce infection. All of these, that's what healing is about. And if they have anything but an idealistic healing potential, well, that your risk of a problem may just simply increase. So therefore, what can you or the patient do to help to make the outcome more favorable? And sometimes just because I learned the hard way that just because I have a medical history form and the patient has ticked it, say, big fat tick in the box, no, it doesn't necessarily mean that they've always told you the truth. Sometimes they simply just misinterpret that question, or simply didn't even read that question. That happens all the time. Almost on a weekly basis, I would have a patient that ticked no, and when I ask the patient into it, then they will tell me half a dozen of things that they do probably take. Or sometimes the patients may simply just not tell you certain things deliberately. For example, this picture that you see on screen is a patient who is on cocaine, and she was too embarrassed to write that down, didn't tell me about it. Otherwise, she appears to be a fit and healthy 30-year-old patient. And by the time when I finished placing the implants with lots of grafts, 2 days later, I received a phone call from the local registrar from Manly to say that I have one of your patients here. She's in severe pain. She's too embarrassed to come in to your practice to tell you that she is on cocaine, but otherwise, you do need to see her. And that's perfectly fine, but I just wish that I knew her medical history, because I would have tackled this very differently. I would not be doing all these complicated procedures with a wound which is simply dehisce every 2 days. So for this poor patient, I saw her every second day. The wound was simply dehisce, and I would just keep on putting in more sutures. It's not fun for her or for me. And again, all of this could be completely prevented, in my opinion, if only that I could have known something a little bit more. Now, needless to say, it doesn't matter how much I try to rescue it, eventually too much bone is lost in these implants, and we removed all implants, and she's back to a partial denture. Significant disappointment for the patient and myself. Another group of medications that a lot of our patients on are anti-coagulants. And this list, it just keeps on getting longer and longer, which is great. I think there's a lot of different special properties that these medications have, which is great for certain conditions. So I think to give patients all these choices is great. Some of these medications we may be able to get the patient to cease or reduce or change prior to certain surgical procedures, but some of them, like for example Plavix, you may not want to just simply straight away take the patient off some of those medications, because that may place your patient at a significantly higher risk of myocardial infarction within the first 12 months of starting that medication. So I would strongly recommend to have an in-depth discussion with a medical practitioner who is looking after the patient before considering ceasing some of these medications. Another group of they're not medications, but they're supplements that often catches me out is things like fish oil or krill oil, turmeric, garlic, vitamin E. Especially these things are working synergistically. Sometimes some patients could even be on some sort of a Chinese herbal medications, and God knows what's in there. It doesn't even say in the packet, what's in it. And there's a lot of stuff that they use, whether it's ginseng or whatnot. Again, synergistically, they can act as a very potent anticoagulant. And all the patients that in the past 15 or so of my specialist career, that the patient end up checking into the local hospital after hours, it was never the ones on a medication of a coagulant that I knew of. Historically, has always been them on a variety of supplements. And previously, I never even bothered to ask that question, because I was never taught at an undergrad or at a specialist level to ask those questions. So I had to learn from my own mistakes. And then I've learned, you don't just get them to stop their aspirin sometimes. So you got to stop the 5 fish oils that they take on a daily basis and that kind of stuff, because that's what really sometimes pushes them over the line. Yeah, so supplements is another thing to watch out for. We don't need to go in depth into smoking. We all know that smoking significantly increases the risk of whether it's dry socket or infection, particularly after, say, grafting, because that significantly reduces the angiogenesis or the healing potential of that region. This is one of those patients that is a smoker who has already ceased smoking recently. So when I placed an implant, to reduce that risk further, I used a 2-stage protocol, so everything's completely covered. But even then, due to poor local vasculature, there is crestal bone loss after 3 months. And again, there's not much you can do about that. Last but not the least, expectations. We can all have patients who have a high level of expectation, or sometimes they're just simply not so reasonable about things. Maybe not rational, maybe not sensible. Maybe you just can't talk science to them. And if you can't have a logical and a rational conversation with them, we'll think twice about whether you want to carry out potentially invasive surgical procedures. Because if you can't even hold a rational discussion when no complication has occurred, how do you think that conversation is going to go when there is a complication that didn't quite go your way or their way? How would you able to rationalize having a rational discussion then, right? Often you can't, because that patient was never rational to begin with, and they're certainly not going to become rational all of a sudden when there's a complication. In fact, it's the other way around. So sometimes you may find that initially you do have a reasonable professional relationship with the patient, but very quickly you lost control, and that professional relationship just went nothing but downhill. And then we're all scratching our heads and going, what just happened? And sometimes there are these warning bells at the beginning. So look into your own ways of patient screening, and having a very defined, clear line on which type of patients that you feel comfortable treating, and more importantly, which type of patients that you do not feel comfortable at treating. And that's where you draw the line. And it's okay. Everyone has that line. Take this case here, for example. This is a 40-something-year-old solicitor. He recently has received an extraction from the referral, which everything was fine. Everything was uncomplicated. The healing is fine. He presented about a week or two after the extraction, and the healing socket is normal. He's not in pain, and he just wanted an implant. He said that, I heard you were fairly good at doing implants. Let's get going, because I'm a solicitor and time is poor. And I said that's fine, but we do need some sort of radiology assessment. Some sort of a CBCT would be nice. And that's when he refused. So we spent the next 45 minutes discussing how to make it safe, that radiological assessment is safe, and what we can do to make it even safer. So for example, we can use a small focal view. We can even get him to wear a large lead apron, all those sort of things. Or heck, even just let me take a PA at least, so that at least I'll go old school. Visually you can see that he's a bruxer, so he's got a fairly wide ridge. So probably bone width is not a problem. I'm just worried about the position of the inferior alveolar nerve, particularly for a solicitor. And it doesn't matter what I say. His answer is no. He just said that, I'm sure it's fine. There was a tooth in there before. I'm sure you can just put an implant in there. And I just did not feel comfortable, in part because I don't have an X-ray, but largely because I felt that he was unreasonable. That's not what a reasonable patient will respond when you have a logical discussion with them, that it is in your best interest. It's not in my best interest that when the nerve goes numb, nor your best interest. It's for your safety. So if you can't have some changes in your perception, then all I could say to him that I don't feel that I am have enough experience to tackle cases like this, and I would strongly recommend him to go to a mentor or someone of mine, or someone with a lot more experience than I do, to carry out these procedures. And bye-bye, essentially. So I'm sure we all had those patients before. So let's and of course there's another a very common medication or type of group of a class of drugs that patients take for the management of osteoporosis, which is bisphosphonates or Prolia. Zoe, could you tell us a little bit more about that, of what it is, and how to risk assess? Because that's one very common question that we get, which is the patient is on bisphosphonates or Prolia for some time. Are they low or high risk? And how do we prevent it?
Sure.
Thank you, Zoe.
Thank you, Ben. Thank you. Yes, so definitely another group of medication, as you mentioned correctly, is anti-resorptive medications. Now, the issue with the anti-resorptive medication is the cases that we see with medication-related osteonecrosis of the jaw, MRONJ. So according to Rogero 2022 position statement, which was published by the American Association of Oromaxillofacial Surgeons, on this condition, they classified it as a condition or a disease that might present itself in a way where there is a patient who has anti-resorptive medication, so either a current or a past history of the anti-resorptive medication, as well as there is an exposure of bone in that patient. And that exposed bone can be either probed through, or a fistula that might be probed through. And that usually lasts for about 8 weeks or more. So it has been persistent. It doesn't just heal straight away. Now, these patients also haven't been on radiotherapy, so there is no confusion in the causative factor for the related osteonecrosis of the jaw, and they don't have metastasis. So when we look at the anti-resorptive therapy, there is a range of conditions that these medications are used to manage, and generally they are then classified into the osteoporosis-related prevention of fractures, or there might be cancer treatment, spinal cord compressions, and other malignancy or metastases that the doctor might feel that the patient will benefit from these medications. So if we are to look at those medications in particular, and we think about the classification of them, so first of all, we might have the bisphosphonate groups. So bisphosphonates, they are given either in two forms, either orally or intravenously. So the oral form is the medication we are used to hearing about, so Fosamax, Actonel, or Ibandronet. And then the IV form, we've got the zoledronic acid medication that is more so used for cancer management. Now, the bisphosphonates, they tend to bind to bone. Hence, they prevent the osteoclast from resorbing the bone. Now, the reason these medications are given is because several studies have shown it does actually work in preventing fractures. And that is important for a patient who is susceptible to fractures. The other group of medications, the anti-resorptive medication, is denosumab. Denosumab is what we commonly seen patients taking Prolia. So it is a monoclonal antibody that is acting against or inhibiting for rank L. So rank L is actually a short for a receptor activator nuclear factor kappa B ligand. Now, that denosumab is actually binds to the rank L and inhibits the osteoclast function, and therefore inhibit the bone resorptive process. It's usually given subcutaneously every 6 months. So when that's happened, at the end of the 6 months, the patient will receive another dose of the Prolia, and it does work by preventing or reducing the fractures in these osteoporotic patients. So here we can see the difference between the way bisphosphonate works or the rank L inhibitors. So bisphosphonate, it binds to the bone, so that's the green sort of is it pentagon? Yeah, kind of yes. Figures. So it binds to bone and it prevents the activated osteoclast from resorbing that bone. Whereas the rank L, which is Prolia, it binds to the receptor, to the rank L, and does not activate the osteoclast. So the osteoclast cannot resorb bone, so you've got a lot of activity of the osteoblast forming more bone. So what do we think about these patients who come into our surgery? What are our advice to them? There's a lot of talk about, should we go on a drug holiday, have a period of time that where we cease taking these medications, or do we carry on? What are our risks there? And what has been reported in the literature? So with the drug holiday, there's so many studies that have shown that, especially in patients who are taking denosumab, there is a rebound increase in bone resorption following the discontinuation of the medication. And as a result, you expect that there is a multi-level vertebral fracture. So there's an increasing risk of fractures. So there's a bit of a concern of finding the right time or time frame to ask the patient to stop this medication without increasing the risk of developing the fractures for the patients. So again, the American Association of Oromaxillofacial Surgeon position paper recommendation is to 4 months after the last dose of Prolia to complete any sort of surgical intervention for the patient. So they feel that the dose of the medication in the patient's blood have reduced or waned enough for them to be able to do the surgery safely. And then after a healing period of about 6 to 8 weeks, they recommence the patient back onto that medication without delay. And they feel that this is sufficient to minimize the risk of developing the fractures, but also carry out the procedure safely. Now, of course, there is a variation to this. So some recommendation is to wait 5 months. Others might wait past the 6-month period, but this is what the paper actually recommended. Okay. So how does, what is the pathophysiology of MRONJ? So what contributes to developing that disease or condition? There's so many factors, and initially it was thought that it is less issues just related to having the anti-resorptive medication, but nowadays, after so many research and study that has been carried out, they're finding that it's actually multifactorial. So there's many elements that interact and play together in a patient that increases the risk of that patient developing this condition. So the first thing is, of course, they have to have a history of the anti-resorptive medication, and then there is some sort of an infection or inflammation. So there's some bacteria, maybe like microflora, that might increases their risk of infection, and the medication itself will cause some sort of a soft tissue toxicity, and this is the direct effect of the bisphosphonates. Now, combination with that is the blood supply is important. So angiogenesis is quite important to help with tissue healing and bone development. And they found that if there is a reduction in the potential of angiogenesis in a patient, that increases the risk of developing MRONJ. And also if their immune system is compromised for whatever reason. So all these factors, and on top of it, there might be a dental contribution to it. So there might be a dental infection, there might be a denture, ill-fitting denture, periapical infection, periodontal disease, something like that, that will kind of trigger that patient to develop the disease. So how do we look into assessing that patient, and why is it important? Now, we need to understand the risks that these patients have. So, for example, for bisphosphonates, it is 2 to 4 cases per 10,000. So it is a kind of a low risk for them to develop MRONJ. But it is a serious enough condition that we really need to be aware of. And if they're taking demoximab, then their risk kind of significantly increased to about 30 per 10,000 cases. And if they actually have a cancer treatment or cancer patient, then they might be taking an IV form of bisphosphonates, for example, the zoledronic acid. Then there is a significant increase in the patient presenting with that medication-related osteonecrosis. So 33 times increase in that condition. The time that they've been on this medication for, so anything more than 3 years is considered a long term, and that tend to increases their risk. And whether there is any other factors that might like systemic corticosteroid, which talked about their immunocompromise, some other condition that might increase their risk as well. So here we've got the risk assessment of these patients, and it's kind of, if you think about it, about a lower dose of the medication and a higher dose of the medication. So with the lower dose of the medication is the patients who are actually on the oral form. And they have been taking it maybe less than 3 years or more than 3 years. With the higher dose, they're usually the IV form of this medication. So if they have been taking this medication for less than 3 years of treatment, and they've got no other combination of factors that might increase their risk of developing the disease. For example, they're not on corticosteroids, they don't have any chemotherapy, they're not immunocompromised, they've got reasonably good oral hygiene, they don't have any dental condition that will increases their chances of having an issue, they're not a cancer patient, then these patients generally considered a low risk for developing MRONJ. But once that has more than 3 years of treatment of with the anti-resorptive medications, then straight away they consider to become a high-risk patient. And if they are on a higher dose of the medication, then again they are a higher risk. So kind of time frame, I suppose, of seems to be the time frame of being on that drug is the risk increases your risk significantly. So how do we look into classifying MRONJ? And the reason for classification or staging system is it just makes the treatment rationale or guidelines for staging these patients and then carrying out the treatment protocol according to each stage that they at. And then assessing whether they are responding to treatment by going down, for example, from a stage 3 to stage 2 or stage 1, or actually deteriorating in their condition. So if we look at stage 0, and this is a difficult stage because it doesn't really have any specific presentation. It's just non-specific pain. They are symptomatic. They might present with non-odontogenic tooth pain or some teeth mobility, some radiographic changes that might be evident, but we can't kind of pinpoint what's the causative factor for it. So it is a condition where it's really difficult to put your correct diagnosis on. So with radiographic finding, it might be just widening of periodontal ligament or maybe even narrowing of that. So that's what a stage 0, but it is a symptomatic stage.
Which there's no bone exposure. That's the trickiest part, isn't it?
There is nothing specific at all. So it could apply to any other dental condition. And then stage 1 is becoming a bit more clearer in terms of the presentation. So it is, in this case, it's asymptomatic. So the patient may come in for the regular checkup or review, and you pick up on these little spots on adjacent to their implant or in the soft tissues. And so there is an exposed or necrotic bone. There might be a fistula that you can probe all the way to the bone, but there is no infection, there's no pain, there's no inflammation. They may have some radiographic changes, but this is what's called a stage 1. But then once they become symptomatic, and the area is actually the exposed bone or the necrotic bone might be slightly getting bigger. It's also contained, so that fistula contained within the alveolar bone process. So it's not extending beyond that. So this is a stage 2 still, and there is some inflammation and infection. And then as we move to stage 3, where that sort of necrotic or exposed bone or the fistula, it doesn't only involve the alveolar bone process, it may actually extend beyond that. And there will be infection, inflammation, there might be an oroantral fistula, or communication or extraoral fistula. So bony fractures. So there is a bit more progression of the disease, and it's a lot more serious when it comes to stage 3. So how do we prevent it? The main thing in prevention, and all of us can have a role to tell our patients and educate them about their condition, or they're taking a medication, certain medication that predispose them to that MRONJ, and ensuring that they don't fall into that path or minimizing their risks. So helping them maintain good oral hygiene, the importance of why they need to maintain that, and also ensuring that they dentally fit and healthy, so there is no carious lesions, there's no periodontal disease that goes unchecked or unmanaged. If there's a need for endodontic treatment, then carry out that treatment. And if they're wearing a denture, make sure that the denture is well fitting, especially on a lot of the denture flanges on the lingual plate. At the posterior region, it's a very susceptible part that is susceptible to trauma, and a lot of the time the denture might be rubbing on that lingual plate and creating an issue with soft tissue abrasion or exposure of the bone underneath it. So carry out everything that you need to carry out in terms of dental health, ensuring the patient is fit and healthy, and also counseling about smoking cessation, anything that will improve the blood supply to the area, improve their general health. Once the patient is on anti-resorptive medication or therapy, and you need to carry out a surgical procedure, then commence that procedure or carry out that procedure prior to them starting on that surgical, like anti-resorptive therapy. If they're already on the anti-resorptive medication, and you're choosing between endodontic treatment or surgical extraction, perhaps endodontic treatment might be less traumatic, so that way we can reduce that. Also, there is a recommendation for some sort of preoperative and postoperative antibiotics, as well as antimicrobial mouth rinses for patients who are at a higher risk about to undergo surgical intervention. Now, primary closure of extraction site is another way of minimizing or improving the healing potential for the patient, but keep in mind that it is always, if the site, if you cannot achieve primary closure, it's better to cover it with a spongiosand and sutures and let it heal naturally, as opposed to raising a flap where you could potentially create further trauma to the patient and maybe induce the MRONJ for them. And if the patient has a malignant condition or disease, then avoid surgery at all costs, and consider like a root like decoronating the tooth and maybe retaining the roots as opposed to extraction. And of course, avoid dental implants in cancer patients who are high risk. So when we look at the risk of implants, and I guess we all think about that when we're about to place an implant in a patient who is on anti-resorptive medication. Does that put them at an increased risk of developing that condition? And there hasn't been really a consensus in the literature. There's a conflicting reports. There are some studies or systematic reviews that they found that yes, there is an increased risk of MRONJ developing around the implants, especially if the implants in the posterior mandible. And usually they found that most of implant failure happened at a later stage. So it's a late implant failure that they've been in the mouth for more than 12 months. And sometimes these implants have been placed before the patient was actually commencing on the anti-resorptive therapy medications. But other studies, they found that no, there's no correlation or there's no increased risk. So I guess that where do we stand here in terms of what do we advise our patients? I was looking at what's the consensus, and apparently because of there's no enough data to tell one thing than the other, the recommendation was to give the patient an informed consent that they are at a lower risk of developing MRONJ, and there is a possibility of early or late implant failure, and they need to understand that they have to maintain their good oral hygiene, have dentally sound and healthy, and they attend a long-term recall appointments to ensure that we pick up anything along the way that might become problematic for them. So this patient here, she's 85-year-old. She's received, she's had some implants done in the canine and the premolar position. And she had some previous implant supported bridge in her lateral, I think lateral to lateral. So she was on Fosamax for 7 years, and then she changed to Actonol for about 1 to 2 years, and then she was on Prolia for more than 5 years. So I guess from what we discussed previously, I suppose this patient is considered, because of the long-term use of the anti-resorptive medication, considered to become a higher risk patient for developing MRONJ. So everything was okay, going through the healing stage, implant impression, and then restoration of the implant. And later on, a few years later, she actually presented with a pain, so that she kind of located at the front of the canine. So mesial, she pinpointed between the mesial of the canine and the lateral incisor. And with time, that pain became radiographically evident that she is developing some sort of sequestrum or bone loss on the mesial aspect of the anterior implant. So that's the patient who had implants in the past, and she had long-term use of anti-resorptive medication, and she had to have some management of this implant, or potentially failing implant.
Yeah, so we referred her to, after initial, just more simple sort of surgical debridement, but that problem didn't go away. It would go away for maybe about a week or two, and then it would just simply come back again. And that's when we made the referral to our max-vac surgeon. Different people will treat them differently, but in this particular incidence, that particular max-vac surgeon decided the explant was the better solution. So remove that implant and put a little bit of graft material there. So she has recovered well. I think over the last couple of months, there's been another bout of some more sequestrium coming out. So it's very unpredictable at times in terms of the surgical management of these things. Which is you're at the mercy of the patient's body, how those cells are reacting, and we are surgeons. We do not have any magical powers to change their osteoclasts.
Of course not. So in terms of management, refer. If you come across a patient who is presenting with any stage of the MRONJ, definitely refer them, because there's different management. A lot of it based around mostly conservative at the early stages, perhaps some sort of antibiotic, antimicrobial rinses, maybe some debridement, but definitely it is way beyond our management protocols or referral to the specialized person who deals with this condition, which is usually the maxillofacial surgeon, is the recommendation.
I'm so happy that Thao, our resident oral surgeon, is here tonight to go over a lot of the surgical relevant management of these cases. Because Thao, in the hospital, you've seen a lot of these. There's one particular clinic that's just dedicated for MRONJ, right?
Yeah.
So I know you have a lot of experience managing it. Can you go through with us, how do you deal with these?
Yeah, thank you. Thank you, Zoe, for going through really kind of updating the audience on what the current recommendations and guidelines are. But it's really important to understand that there's no single recipe for a lot of these cases. I do get a lot of people asking me, what do I do in this case and what do I do in this case? Because it's the spectrum so broad. And for the next few cases, I wanted just to kind of give an idea of why it's really hard, because it's really patient dependent. As we said, everyone heals differently. Everyone's on a different scale, and none of us are magical. We can't predict how they're going to heal. All we can do is make the right choices based on experience and what we've seen. And I think what helps with the experience is familiarity, understanding where this may go based on previous experiences. So the first case I just wanted to show is just showing you that it's not always surgical procedures or extractions that can actually initiate MRONJ. In this case, this is a periapical pathology, which has been a lot of patients with periapical pathology have no pain. You know, you have a lesion. Over time, what happens is you get that necrosis occurring around the inflammation, and then it becomes avascular, and that there is you're seeing the sequestrum coming through. Now that management is quite difficult because endodontic treatment won't resolve that issue now. Essentially, that tooth may need removal, and then with a debridement of the area, and then it's an anterior tooth, the patient might need replacement. So that's where our prosthodontists are really important in really helping us look at non-surgical ways of replacing teeth at this point. If a patient has a history of MRONJ already, the likelihood of them getting MRONJ again is quite high, because it's telling you they have that history. You're really fighting nature if you think they won't get it again. So the next case is interesting because it shows you that MRONJ can probably resolve. So what we haven't spoken about is anti-angiogenic medication, because we're talking about MRONJ, which is any type of medication. So currently there's case reports looking at methotrexate and mTOR inhibitors and a few other. It just keeps getting bigger and bigger. This gentleman, he was referred because he actually had bilateral bony exposure of his lingual tori. His oral hygiene is actually, excuse my photo, but his oral hygiene is actually quite good, and he had no pain. He was going through anti-angiogenic therapy for his small cell lung cancer. And what I found was good oral hygiene, no pain. Let's have a look at the area. And I noticed that both sides of the sequestrum was actually quite mobile. One area was probably more mobile than the other, and I was able to really pick it out really easily for him, causing minimal trauma. The other side, not as mobile. And I said, look, I'm going to keep an eye on you. I'm going to look after you, make sure that I'm going to follow along and that you don't go down the wrong path. And his oral hygiene was good. He was a good patient. And after the second week, he came and gave me that jar. And he goes, it came out by itself, like you said. And I looked in his mouth, and it's complete epithelialization of the area. So I didn't really need to do anything, but that monitoring and reassurance was really important for the patient. So and he had a good dentist who was looking after him and was good enough to actually notice that, because some people don't look that far back, especially if the patient is asymptomatic. So that was a good case. This is another one. So we have an 85-year-old female. So she had her lower anterior teeth removed simply, just simple exos 9 months earlier. Now she has a 5-year history of prolia and more than 10 years of Fosimax. Now you can imagine the extraction was done by her general dentist, was done well, and with antibiotic cover, everything looked good, and the patient went away, no issues. So that's why it was 9 months later. But she had her denture made, and suddenly her dentures stopped fitting, and she noticed buccal and lingual expansion. And then she was referred for us to have a look in the oral surgery department. And when we took the cone beam CT, you can see the basal bone appears sound, but there's this large sequestrum, and you can see that obviously on the cross section. And so in this case, this is not going to self-resolve, no way. And how are we going to? The patient can't wear denture. She's losing weight. She was a very little Asian lady. And so how can we help this patient? So in this case, we're going towards a more conservative, it's still conservative because we're really removing sequestrum. So they call it a sequestrum. So I did this is the surgery I did.
That's a word.
Yeah, it is. Anything with ectomy means we're removing it. So sequestrectomy. So, so this was just a minimal envelope flap, and you can see the sequestrum came out really quickly, and it was quite an impressive large one, and very little debridement required, just any sharp bone around the area, and then and you can see how large that sequestrum was. We always send this to pathology. Anything that you're removing from the patient, even that little bone that the patient came with in the jar, I sent to pathology. You want to, because he had small cell cancer, so you want to make sure it's not metastases. And here I achieved, this is just immediately after, and she recovered well. We achieved primary closure, and I referred her to the prosthodontist to make a nice fitting denture for her, because she still has actually some posterior teeth there. And that was the management. So it kind of shows you that spectrum, but it's really important to understand that it's not a one size fits all, and it's your assessment of the patient, and you really don't want to make it worse for them, but you need to understand that a lot of them can be in discomfort, and if they can't wear a denture, if they can't function, that quality of life is just as bad. So it's a fine balance of taking care of your patient, and involving a multidisciplinary team. You know, we can't do it all ourselves. Yeah.
No, that's a very difficult case, very well managed.
Okay.
Continue to send in your questions, ladies and gentlemen, and again, I'll try my best to directly as well as I could to the rest of the table. There's another question about whether I think it's for that patient who was on cocaine with a large wound dehiscence. And the question is, do we leave the implants or do we remove it? In that particular case, I actually removed the implants because there was significant bone loss at the crestal area, and I thought if we did leave it, sooner or later, I think that wound dehiscence, tissue, implant exposure could occur, and that may not be in her best interest. So it was based on that I removed all 3 implants, despite the fact that they were osseointegrated, but just had significant crestal bone loss. That it's not reasonable to use. Interestingly, so we carry on with surgical related topics. Recently, quite interesting on DPR, I saw one dentist made a statement about how that she wasn't able to get a patient numb, something like 2 patients numb in one afternoon, and how that has completely devastated her self-confidence. And I think that can happen to all of us, whether it is for a restorative procedure, whether it's for endodontic or whether for surgical procedure. I'm sure we all had it before, that you sort of tried everything. After the 8th cartridge, you're like, I think I'm hitting the limit here. But the patient is still going, ow, I'm feeling something. Now, Thao, you do some pretty big surgeries. So what tips and tricks do you have up your sleeve to ensure that we can bump up that success rate a little bit?
Sure. You can imagine with surgical procedures, you better have the patient numb. You know, that's one thing. You know, restorative, maybe you can go a little bit slower, but with surgery, local anesthesia is so important, and there's nothing more confidence kind of breaking than not achieving anesthesia. Immediately the patient will question your skills. So I wanted to kind of work up slowly. So some of it might appear, I could read this in textbook, but kind of work up to what techniques you can use for the patient. So coming back, the main issue I find with a lot of people who have spoken to me is when their inferior alveolar nerve block fails. Now, we understand that the human body varies so much. To think that it's one recipe for everyone is not correct. The idea is we don't have a single trunk. Most of the time, the inferior alveolar nerve is a plexiform, and there is significant variations in how it branches. And on top of that, there's variations in the ramus, so the width, the angle, and on top of that, there's also variation in where the foramen is, so and where the lingula is. And then you also have bifid canal. So a lot of them may be picked up on radiographs, but a lot of times it can't be. So I think it's important to understand that it's not always the case. You can't just, it's not always 1 cartridge patient or 2 cartridges. It's let's work up and see how this patient responds to this particular local anesthesia. My main concern I find with a lot of students in dental school, I don't know if you remember, but every time they come and ask for another cartridge, it's almost like you're in trouble. You didn't get the block. And I wanted to really change that point of view, because it shouldn't be like that. It shouldn't just be 1 block and you have to get it first go. It's understanding that there is variation, and also to explain that to the patient. So a lot of patients, when I'm about to do a wisdom tooth removal, I've only put 1 block in, and I'm about to give them another, and they start to go, oh, but yeah, you're giving me another one. Did you not get the right nerve before? And then I learned early on that it's how I spoke to the patient very quickly initially, how to get them to a spot where they're comfortable, I would normally go, let's start with, this is a surgical procedure, and we want to numb you. We want you not to feel any discomfort. So often volume is very important. Okay, so there are barriers to diffusion. We know the sphenomandibular ligament can prevent the local anesthesia diffusion. And often, when you try to do a gout gates, that lateral pterygoid muscle can also prevent that medial diffusion of the gout gates. So there's often a lot of barriers that we can't see. So the main thing for me is I find that there's just not enough volume that people have put in the area, or that you haven't given them enough solution. And a lot of people are going, oh, but I've given like 3 cartridges already. Are you telling me I'm not in the right area? Well, I would kind of come back to reassessing the patient. So this is just the first step, volume. It's not about 1 cartridges. You often have to step up to 1 or 2. Now let's go to the next path, which is accessory innovation. We know that, again, complexity, there is the glossopharyngeal nerve that can provide additional innervation to the posterior mandibular lingual gingiva. And then you've got the cervical plexus, which is normally over the skin, but it can also creep up and give that initial innervation into the buccal aspect. And also we have the mylohyoid, which is not a sensory nerve, but we find that it actually enters the canal and can provide sensory innervation. And finally, the long buccal. Again, it's not a single nerve. It actually branches as it crosses the anterior ramus. So when you often try to do a block, but if it branches out, you're not actually getting the entire long buccal. It requires a bit more volume in the area as well. So I'm trying to get back to really assessing, where are they feeling pain? Sometimes they're numb everywhere, and then you put a probe onto the lingual and they jump and they feel the lingual. So often I just do a small supplementary infiltration into the lingual aspect, and that resolves the issue. Sometimes it's the buccal, deep buccal, and I find that if I do a deep buccal block and I get the cervical plexus, that improves. And then with the IAN, if they're still feeling, if they're not getting that numb sensation on the lower lip, and you've given 2 cartridges, 3 cartridges, you might have to reconsider maybe doing a more advanced block, or where your block is. Are you not deep enough? Are you just not giving enough volume? If the patient has it's a large patient with a wide ramus, are you just not getting the mandibular foramen in the right area? So it's again part of problem solving, and you're kind of going through that in your head as you're working with the patient. So that I'm going to go towards some of the advanced techniques, but I wanted to go next to a topic that always comes up. That this one question everyone calls it, or everyone likes to get into this by articaine and lignocaine. Some people swear by articaine, and look, there's too much debate in the literature at the moment. For me, lignocaine has always been the standard, but articaine has been shown to be great for supplemental infiltration. So you've done, for our wisdom tooth, for example, I've done my 2 inferior alveolar nerve blocks, and then I do a supplemental buccal infiltration with articaine, and that often works quite well. Now, if you're wondering the controversy between articaine and lignocaine, it's actually, there's also a debate that there could be possible paresthesia associated and nerve damage with articaine. Well, you can't really compare articaine and lignocaine, because articaine's 4% and lignocaine's 2%. So it already has a higher percentage of the anesthesia. So if you're putting a 4% articaine and 2 cartridges for a mental block, there is a risk that there could be damage to the nerve. And when you look at systematic reviews, all the systematic reviews look at papers comparing anesthesia, and if you look down to the risk of damage associated with possible injection, it's actually 1 in a million or 1 in 600,000. So the study doesn't encompass that risk. Okay, but the number of dentists doing injections every day does add up. So for me, me personally would avoid articaine for an inferior alveolar nerve block. I found that lignocaine has always been the standard, and I would prefer to change my injection, the type of injection I'm doing, in terms of changing it to a higher block or an achinosis block, rather than switching to a different anesthetic for a block. But again, open for debate. It's just from experience. I've never had issues where I've had to use an articaine block. Okay. And great. Again, that we come down to, is it just about giving more LA, and is it just about getting the right nerve? We know that high anxiety increases nerve excitability and it lowers the pain threshold. So we need to manage the patient as a whole. So it's not just about the technique and the type of anesthesia. It's about other techniques to help them along. So these are just small techniques I thought it might help people along, other clinicians. But for example, a distraction device. I find that those with high anxiety, but they don't want to go down the sedation path. They really don't want to go down the sedation path. They don't want general anesthesia. They don't want IV sedation. And oral sedation is just unpredictable for them. So I find that using this vibration, it's a massager, a handheld massager, and it's good for patients who are very anxious as well. So what they found was it was much more the efficacy of pain associated with the injection when you use a distraction device as opposed to topical, significant difference.
Well, they just hold it in their hands. And
no, I actually put it on the face.
Okay.
So, and they get a bit confused, but they get a bit excited, and they're like, "Oh, what's she doing?" But
it's a
like,
massage.
it's a free massage while you're getting your local anesthesia.
At the same time as the injection.
Yeah. And what it does is it takes into account the gating mechanism. So when you activate your your A beta fibers, which are bigger fibers, so it can really cut off that signal that's coming from your A delta and C fibers, which are associated with pain. So that's what you're employing. And I find this works really well. And it's weird because now a lot of my patients, if they see someone else, they kind of put the hand out and go, "Oh, where's the massager?" But it's been good for me, and I hope that others can employ that to add on to improving local anesthesia, because improving is not just about, is about lowering that anxiety for the patient as well. Another thing that I've employed quite a lot, and our endodontic colleagues know a lot about preempted analgesia, but for some reason in surgery we don't really, we're slow. And the idea is you want to give a preoperative dose of painkillers. So my standard is normally, as long as they're able to take NSAIDs, is 1,000 milligrams of paracetamol and 400 milligrams of ibuprofen. So 2 paracetamol, 2 ibuprofen, an hour before the procedure. And the idea is, if you know, firstly, the patient feels good because you're teaching them that we want preemptive and then we want on-the-clock analgesia. Yes. It's preparing them. But it's actually shown to improve post-operative pain. And also, in some cases, in endodontic procedures for irreversible pulpitis, it's found to improve local anesthesia as well. So I think if your patients have that irreversible pulpitis, or very anxious, or they're worried about post-op because they've had history of difficult extractions, you should employ this technique. And I actually do it a lot for wisdom teeth, for example, for the patients, if it's not general anesthesia. Finally, just a few techniques just to revisit. So gout gates, the idea is it's an open mouth local anesthesia technique. So the idea is you're trying to get the mandibular nerve as it exits for foramen ovale. So the landmarks here is really important, but it bypasses the variability that can occur when it comes to the position of the mandibular foramen and the lingula, etc. So the landmarks you're looking at is that lower border of the tragus, so of the ear, the corner of the mouth, and the angulation of the tragus to the side of the face. So you just kind of draw a line, and the patient's mouth needs to be open as wide as possible. And you can see in the lower picture, on the lower right, you're palpating the anterior border of the mandible. You need to know the ramus. Sorry, you need to know where you're going. And the great thing about this is when your mouth is open, the condyle translates forward, and that area is relatively avascular. And they find that with studies, they get less positive aspiration during a gout gaze as opposed to your conventional inferior alveolar nerve block. And that means it reduces the loss of local anesthesia to the vascular bed. And so the success is, it's meant to be more successful. Unfortunately, studies don't show that. All studies show it is inconsistent. And the reason is it comes down to operator experience. So if you are experienced with giving the gout gaze, it's definitely going to be more, you're more likely to get a successful anesthesia after 2 cartridges as opposed to your inferior alveolar nerve block. But if you're inexperienced, then it's going to appear the same. Yeah.
What are some of the potential downsides of this particular technique?
The patient needs to really open the mouth. So the next technique I was talking about is if the patient comes in, they like can't open the mouth because they've got pericoronitis because of, and they're in pain. So, and this is, again, there's been some studies looking at a few complications associated with this. And in the area, if the mouth is not open wide, often there's been ophthalmic complications, so the patient gets a bit of double vision, diplopia. There's been also a case of temporary hearing loss for patients as well, but only case studies, and they're still trying to figure out where in the anatomy that occurs. But again, this needs experience, but with experience, you have to try it at one point. And we're never taught this in dental school, but I find that in some cases, just giving an additional gout gaze block has been quite helpful. A second block I use quite a lot, and I feel like people should use it more, is the achinosis block. It's a closed mouth block. It's a bit scary because you're not hitting bone. So there's potential to go quite far back, and you're worried about partial facial paralysis, essentially. But the idea is the patient's mouth is relaxed. They're not clenching. And you need a retractor, you need a Minnesota retractor. You can't have a mirror in there. And the idea is you want to be accessing the back of the mouth, and just where I've pointed there is just lateral to the upper sevens. And when you go in, there should really be no resistance. You still aspirate, but don't be tempted to go more than 25 millimeters in. I find it's really good because you can give quite a non-painful block, because if you put a lot of topical there, you use your massager and you go in, and because they're quite relaxed, you don't get that tension of the mouth opening. So you're not going, sometimes you give a block, you feel like you're going through some sort of muscle and the patient jumps. Because everything's relaxed, you can give it quite passively with very little pain. And I do this under general anesthesia for all patients during having wisdom teeth removed. So that's why I'm quite familiar with it. But it just takes a bit of experience, but when it's done well, especially if they can't open their mouth wide, that it's very helpful. And finally, I do this quite a bit for if I need to do grafting in the anterior region, which is the infraorbital block. It's really important to understand that you're actually not, even though the images shows, you're actually not trying to get into the canal. You're trying just to infiltrate the area, and it gives quite a profound anesthesia. The only issue is they do get blanching, so they come, if they go red quite easily, the whole side of the face goes quite white, and it's quite scary for the patient. But it's if you want to do quite, for example, a cover lock procedure, and they're still awake, or if you need to do quite a lot of grafting where you have to lift a large flap, these blocks are very useful instead of just doing a lot of infills in the area. And you can see there's different techniques, but the idea is where your access is easier. The main thing is please avoid the nose. Don't go through make sure you know where your needle's going. And finally, just a few more. So a maxillary block, which is just a high tuberosity block. And this gives quite profound anesthesia of the maxillary portion of the trigeminal nerve, because the idea is you're trying to get the maxillary nerve as it comes out of the pterygopalatine fossa. So and you follow a 45-degree angle just distal of the upper sevens. Very useful again if you're taking multiple teeth in the area, because you get the palatal aspect as well. What you need to notice is that you do get profound blanching of the palate, so it's quite scary. The whole area of the hemi-maxilla often tends to blanch white when you do that injection, so it's quite scary. But again, another one, if you're just doing that one injection, and when done well, it gives quite profound anesthesia. Yes.
For when you're managing MRONJ type of cases where we know that potentially angiogenesis is an issue.
Yes, yes.
Would you still give some of these block techniques, knowing that it's going to give you a lot of that blanching effect, which would potentially reducing the blood flow to the area?
Yeah. I think in the end, you just need to decide why you're needing to do that block, because if you're having to do such a large block, it also suggests you're going to do a large surgical procedure.
Yes.
So you probably want to. It doesn't really come hand in hand. Does that make sense? So for me, like I wouldn't do a large maxillary block because there's no study to show that it's going to cause MRONJ, but looking at it, the logical aspect is it may, because if you're reducing blood supply from the area, even transiently, that can be an issue. And then if you're raising a flap, etc., you're adding more to the trauma to the area.
Thank you so much for all your questions, ladies and gentlemen. We got some very good questions, some of which I've strategically delayed until a little bit later because those questions are more pertinent to the topic that's coming up. So I didn't want to prematurely jump the gun and ask some of these questions. But I am seeing all of them, and I am prioritizing the way that the questions flow. Another topic that we'll introduce this evening is on dental implants. I know many clinicians are placing or restoring implants. But some of the most common problems or that we're seeing may be sort of summarized in these three aspects. One is that it's got to do with implant size. Very rarely these days I've seen an implant that is too big. So more commonly the problems is the implant size is too small, and then as a result something happened. Or that there wasn't enough space, whether it's mesial-distal space, whether it's vertical space, there wasn't enough space, but they still try to squeeze it in, and then as a result something happened. And then last but not the least, the implant is not in an ideal position, whether it's a planning issue, whether it's an intraoperative issue, or some other issues I don't know, but it end up in a very unfavorable position, which is difficult to restore, or biologically it is not helping. So let's take a look at these three issues. Firstly, size. What sort of implant size, whether it's diameter, whether it's length, you should use. There isn't, to my best knowledge, an actual sort of hard rule that you must or must not use certain diameters, because every situation is situation dependent. But this is my sort of general go-to. We've got the implant diameters going down, and what sort of teeth or shape of teeth that we are replacing. Typically, the bigger the tooth is, then like molars, then the wider that implant is, and the more narrower the tooth that we're replacing, then of course the more narrow the implant is. And in terms of length, personally, 10 millimeters is like the shortest length that I would usually go to, sometimes even 13 millimeters. It's possibly because that in our related practice, we get referred an overabundance of severe bruxism. So therefore, to compensate for the significant dental parafunctional forces that is anticipated for the implant to receive, therefore the diameter or the length, or we could say the total surface area of the object that's also integrated, I would also try to make it as large as possible. I'm not on social media a lot, but sometimes I do stalk people, and this is one of those cases that we saw. The dentist is very experienced. They posted up this failure with this molar that's the single tooth implant supporting a relatively large size molar. If memory serves me right, It's reasonably uncomplicated, and about something like a few years after function, the patient complained of discomfort, and before they know it, the implant is loose, the whole thing came out. There's no crestal bone loss, there's no peri-implantitis. The implant is very clean in the surface, and so is the not osteotomy anymore, but where the implant hole is, it's also very clean as well, suggesting that it's not caused because of a bacterial infection. The dentist was very concerned and did not know what the cause is, and was asking DPR, the audience, the members, the people on DPR, to give their input on what might be the cause, so that they were hoping to reduce that problem. Personally, when I look at a very large molar sitting on a small little implant, to me, overloading just jumps at me, especially of all the symptoms and all the clinical signs that they said. It just feels like the total load, mechanical load that's applied to a relatively small surface area has exceeded what that system was perhaps intended to withstand. And the more bruxes I treat, the more I think that we're underestimating the true power of the masseter muscle. And sometimes they break things that you think there's no way they can break, but yet they will break it for you. Other situations, cases like this, I've seen, again, relatively large molars on relatively small implants. That implant has suffered a catastrophic crack in the mid-buccal. And we're seeing a plethora of fractured abutment screws. Every couple of months, there will be a small collection of of these cases / broken abutment screws that we will have to take out. Our strike rate is not 100%, probably somewhere around 70 to 80% that we can get them out. There are cases that we try for hours, and it's still not happening. It doesn't matter what kit, or what rescue kit that they use, or diagrammatically, how easy it looks. Oh, just drill here, go reverse, and ta-da, see that thing come out. Yeah, you try it. It's not that simple sometimes. Yeah, and then we'll have to remove the implant. Yeah, so it is showing that there is too much forces for that particular system is designed for, and therefore there's mechanical overloading, and then something happens. Whether it's something breaks, something comes loose, something, whatnot. So what I'm trying to get at is implant modality is fantastic. That's what I do every day. But an implant or a piece of titanium or a piece of zirconia that goes on top of the titanium is not the management for the reason why that tooth originally failed in the first place, which could be dental parafunction. So we have to go back to the drawing board to discuss with the patient, inform the patient, educate the patient, to say that, hey, there could be a possibility, even it's clear as day that they're a bruxer, but you still can't accuse them of something that they don't personally believe in. So you just have to say there's a possibility that there is some clenching and grinding. Let's just keep an open mind to investigate, to look into it. And then there's a variety of things that you can try, whether it's awake bruxism, whether it's sleep bruxism, whether it's dental habits, whatever that is. We've got to go back to the drawing board to help the patient themselves diagnose it. And then when they recognize, oh, it's a light bulb moment for them, it's all these years, I'm the culprit, I'm the one that's breaking the fifth crown that the patient... Exactly, they have to take ownership, because if they don't, sooner or later, your implant can just fail. And then that's when the finger is going to point at you to say, what cheap titanium are you putting in my mouth? And then it doesn't matter what you say, it would simply sound like an excuse to them. So management of dental parafunction is paramount. And so while we're on this topic of size, I just done some sort of quick, simple maths, just making certain assumptions that an implant is it's like a cylinder. It's not a true cylinder, but it's something similar to a cylinder. So if I just apply the basic maths of diameter and length versus what the surface area is, so you can see that for a standard ish implant, which is the RP 4.3 by 10, you get a surface area of 164. That's from the first line. And if you could at a molar site, place a wider implant, which is the one all the way at the bottom, the WP 5.5 by 10. So you've gone up the diameter by 1.2 millimeters. But you could also see that the surface area increased from 160 something to about 220. So that's about a 50% increase in your total surface area of your rod, or of the cylinder. Now, bone to implant contact ratio is not 100%. We know that at best. Some of the cases are probably only 60–70%. But by simply increasing the surface area, that would also increase your bone to implant surface contact area, and therefore your resistance against these high, heavy forces. So whereas if you're increasing the length of the implant from 10 to 13 millimeters, you're of course, you're also increasing the surface area, but it's not as significant as when you go up in diameter. So the point I'm trying to make here is, if possible, go to a slightly wider implant. That's assuming it is safe to do so. You have plenty of bone to do so. You have plenty of safety distance, mesial-distally, bacopalatally, to do so. Always, I would place a wider implant whenever I feel that there is a greater loading potential onto the site, to protect the implant a bit more. Here's an interesting question about, for bruxis, would we consider an external hex over an internal hex implant? I spent many years placing external hex implants. You know, when Noble Biocare and University of Sydney had that sponsorship deal back in the day, so when we were going through, you know, all the implants were that were not donated, but as part of the program for us to use. They were external hex, the implants, and then subsequently after graduate, for years, I put in a lot of external hex implants, and it certainly worked quite well. Mechanically, I haven't actually found too much of a difference, just anecdotally, between external and internal hex, although all the studies are showing that internal hex implants are better at distributing that crestal load, so that internally that load is being internally distributed, therefore there's lesser stress onto the crestal bone, and therefore that may translate to a better crestal bone stability, and also lesser mechanical complications in terms of screw loosening, exactly. So in theory, I think we would recommend using internal hex implants, even for bruxis. But anecdotally, whenever an abutment screw fractures, whenever it's an external hex implant, because there's no mechanical cold weld, right, binding internally, so therefore the whole basically abutment or the prosthesis comes off, and then all the screws inside are loose. They're really easy to remove. Whereas for internal hex, it's not necessarily always so easy.
And it's also deeper as well.
Yes, it is deeper. So, I mean, this has got to do with management of a relatively rare complication, and I wouldn't, I think, only use that aspect alone in this particular context. I think the 99% or 99.9% of the times is crestal bone loss, or crestal bone is ever more important. Abutment screw loosening, or that factor is more important. So I think I would still favor an internal hex, a well-designed internal hex implant in bruxism. Any thoughts on that, guys?
Unless if it's like a multi-unit case, then perhaps it doesn't matter if you're going to go to abutment level anyway.
Because you're going to use a multi-unit abutment anyway.
You're going to use a multi-unit abutment, so it makes restorability easier if it's an external hex, because you don't have to go engaging into the abutment as well.
No, absolutely, So for most of the implants that you see coming out of my practice, that's my standard molar implant. It's a 5.5 by 10. Very rarely would I go anything smaller than that. And if it is safe to do so, in fact, I will even go a little bit longer, 5.5 by 13. If there's plenty of clearance away from the inferior alveolar nerve, because quite often when you see these patients with that bone height available, they're usually quite tall, they're usually quite big, and they usually got pretty big jaws. So sometimes I feel that if the previous route was pretty darn long, there's probably a good reason for that. And I'm probably being a bit, too silly of just going, I'm just going to stick to my 10 mil and because I'm happy. Yeah. So I try to see what is the biology giving us, and what was it initially designed and intended for that particular jaw, for that particular muscle, and maybe I should do something similar. And if I don't have enough bone, like in this maxillary case, I would graft. Particularly, you can see that with a lot of these distal units, the horizontal bone level has shrank quite a fair up apically, and there's nothing you can do about it. So that means your implant is placed deeper, and the deeper your implant is, then prosthetically speaking, the longer is going to be your implant crown, and the longer your implant crown, and if you're using shorter implants, well, then that prosthesis to implant ratio is just going to get larger and larger. And there are some studies that suggest that anything more than, say, 2 to 1, definitely 2.5 or 2.3 to 1, you're having a significant risk of overloading that implant. So quite often these days, you can see that the sinus lift is way beyond the implant. And quite often, I'm actually placing 13 millimeter implants now in the upper maxillary side, just simply because we can successfully graft that much. Whether I'm putting in 10 or 13 millimeters of bone, what is the difference? And if I can increase, again, the total surface area in a safe manner to do so, why not? What is the harm? In this case, it's the most distal unit. It's in largely grafted bone. It's in a bruxa. A lot of heavy forces put onto it. So maybe I should do something to compensate for the load. In terms of space, here is another DPR case where this dentist recognizes that the space for the lateral incisor is too limited. So they carried out orthodontic treatment prior, probably to improve the occlusion and also to improve the spacing. And thereafter, they placed a narrow, it appears to be a narrow platform implant to their best ability. They got it in there, but we can see that it's quite close to the at the mesial aspect, so probably tooth 11, I would think. They also posted up the immediate post-pros PA, and here we can see that at the mesial aspect there is crestal bone loss already, and from an execution standpoint, they've probably tried to do everything perfectly right, but the reason why often you see loss of bone in these scenarios is because there's not enough space, leeway between the implant to the tooth. Now, just because there's enough space for us to get that implant in there, it doesn't necessarily mean that's the best way to do it, because there is plenty of evidence recommending us to have an ideally, or at least a 1.5 millimeter space between your implant to the neighboring two teeth. And that is so that there is enough blood supply that is entering that bone. And if you have, say, 0.5 millimeters of bone between the implant and the tooth next door, well, and also we know that when we place the implant, we want to get good primary stability. So in other words, the osteotomy is smaller than the actual implant. So now the implant is compressing onto that very thin bone. It's thin enough as it is, and now with extra pressure onto it, there's going to be even more pressure. And we haven't even spoken about how's the healing abutment fitting into that site, and what's the emergence of the healing abutment, if any. So that's why you just need to have some space. Give it room for the blood to flow, and therefore for your bone to become stable. So if you're placing a reasonably narrow implant, let's say around 3.3 millimeters, that's already pretty narrow. That means in the total mesial-distal space for safe implant placement, I'll say it's somewhere between 6 to 6.5. That's the bare minimum. So if you have anything but 6 or 6.5, you probably have to think twice about, is it still safe to do so? For example, this case here, I've used a calibrated PA technique by sticky tape a known and a radio opaque object. In this case, it's just a paper clip that I digitally calibrated to exactly, or digitally calculate or measured to exactly 5.00 millimeters. So now we can tell the software that's 5, and therefore what is the interdental space, and that's 4.9 something. So that's not more than 5, and therefore for me that is not a safe place to place a narrow platform implant, although it is greater than the diameter of the actual implant itself. So this 5 millimeter or whatever that interdental distance that you're measuring, I'm not referring to the intercoronal distance. I'm referring to the intercrestal or the interapical distance, because we all seen cases where that restorative space is quite small. Like this young lady, she's have this congenitally canine that's missing. She's been wearing this removable Valplast denture for about 7, 8 years. She's now coming of age, and she just wanted to get an implant to get rid of that denture. So when we first saw the restorative space, we can all see, oh gosh, that is tiny. That is not 5 millimeters. And maybe straight away you say, that's not enough space for an implant, maybe. But when we started taking some measurements, as you can see on these measurements on the right side, the intercoronal distance is 4.4, that's very narrow, but the intercrestal distance is 6.5, and the interapical distance is 8.3. So from a surgical standpoint, that is actually safe to place a narrow platform implant. Restoratively speaking, I just need to increase that restorative space. So that could be some minor odontoplasty or something rather, which is what we did. We placed the implant. There's still plenty of safety distance on either side. In a restorable position, we carried out about 0.5 mil of odontoplasty on either side. So the total restorative space is now somewhere around 5.5 millimeters, and then we gave her a small tooth, and which she is completely aware of from day one. She didn't want any further orthodontic treatment. She's used to having this little denture with a little tooth. She felt as though it was like part of her identity, so she doesn't mind it at all. While there's no it does not have this mirror balance to the contralateral side. It's not even close, but in her mind, to her, it's a very aesthetic and acceptable outcome without doing a lot of more complicated type of treatment, and yet it is safe. Another space that we're talking about earlier, not just mesodistally, but also vertically. Very common, the patient may have enough bone, but there's just not enough inter-arch space. So this case was referred to say, hey, Ben, let's get some implants in there. And bone volume-wise, this is actually a slam dunk. But as we can see, not anywhere in those missing teeth, whether it's quadrant 1 or 2, there's just not enough inter-arch space at all for the ideal prosthetic development for missing teeth. There's plenty of studies that will tell us that you need at least roughly 3 millimeters from the crestal bone to your soft tissue, and then further on, at least 5 millimeters from the soft tissue to the opposing teeth, and that's the absolute bare minimum. This is not even to say the ideal. This is the bare minimum that mechanically things can fit together without breaking tomorrow. And if you did a molar that's 5 millimeters, then that looked like a pancake, right? And this is applicable for single units. This is not when you're doing your 3-unit bridge or you're doing a splintered prosthesis, because if you only have 5 millimeters of zirconia, for example, in a severe bruxa in a bridge, and that will break sooner or later. So take this case for example. The implant was placed by a surgical colleague, which was then subsequently referred to our practice to restore, and that is the final outcome. Now you may feel, what on earth is this prosthodontist doing? Clearly he's forgotten to take his meds. Why did he make a mushroom? Well, that's simply because the opposing tooth has over-erupted, number one, and number two, the cheek has enlarged significantly, that the patient was going to undergo cheek biting. So there was no way to give the patient any functional an outcome without making a prosthesis looking like that. I did that crowd. I'm not proud of it, but there's nothing else that I can do given the circumstance. The emergence profile, especially in the meso aspect, is horrible. It's very difficult for the patient to floss. There's definitely plaque that's underneath. That's very difficult to clean. But when given lemons, you make lemonade. You do the best you can. You know what else am I supposed to do? Tell the surgical colleague to take out the implant and do it again, right? No, that's not fair to the patient. So you just have to do the best you can. But in hindsight, you know, we're talking about this from a learning perspective. You know, if we were given the opportunity to redo this case, what will we do differently? I would say the first is maybe knowing that the limited interarch space, you know, could we do something with the opposing tooth? Maybe have a discussion with the patient, or could we place the implant maybe slightly more mesial, so that at least at the mesial aspect, when during the emergence, it's not as steep. Or maybe so that the end prosthesis is not a full-size molar, but maybe a smaller molar, kind of like a cross between a premolar and a molar. So maybe say 8-9 millimeters in mesiodistal space, as opposed to, say, in this case, it was planned for like a 11, if not a 12 millimeter, you know, mesiodistal space molar, so that the emergence profile could be controlled a bit better, or could we place the implant a little bit deeper? Was there any possibility to do so? So this, just in hindsight, these are things I think to take into consideration. And of course, if you are thinking of doing a multi-unit case, that 5 millimeter distance that we previously talking about just literally doubled. And 11, again, it's the minimum. That's not the optimum or the ideal. It's the bare minimum of what a zirconia bridge should have in terms of the vertical thickness or your interarch space. So and again, this is one of my early day cases. I did not obey by those rules, and only within a year, the patient came back with a catastrophic fracture. So I have to go back to the drawing board, remove soft tissue so that the prosthesis could be thicker as a rescue. Or another option could be that this may have to be a porcelain fused to metal a prosthesis, so that we're not using zirconia to compensate for that issue. And if you're doing a full arch or even a longer span treatment, these factors are even more important. This is Brenda. Pam. She's got this sort of terminal maxillary dentition, and she is a fairly severe bruxer. She's got significant loss of bone bilaterally in the posterior region, and I felt something like an all-on-4 is just too much of a high risk, especially that she prefers to have a 12-unit 6-to-6 occlusion as opposed to, say, a 5-to-5 or something like that. So when I designed her or planned her case, I wanted to have 6 implants. That's a perfect spread right across the entire arch from 6 to 6. And in terms of the diameter and the length, 10 millimeters is my minimum length. Some even 13. And to use again wide implants at molar sites, good 4.3 millimeter diameter implants for everywhere else to give it as much support for the entire bridge as possible. We've also previously tested her interarch space and make sure that her removable temporary denture had somewhere around 15 millimeters of interarch space. So that means we have plenty of leeway to develop this bridge, which is a monolithic zirconia bridge. It's been, what's that, six years now under function. Touch on wood, haven't fractured yet, and she's still pretty happy about that. And then lastly, in terms of position, I think we possibly a lot got to do how we can improve on that would be to go back to the drawing board, having good quality scans, using a good software, a digital planning software, to digitally simulate the placement of your implant in the right position, so that you know the exit position of the implant is ideal from a restorative point of view, and then you can even construct or order a good quality surgical guides, so that So that can help you during surgery and make sure the guides are well constructed and well fitted. I'll skip some of these. Once you've used the guide and you carry out your initial osteotomy, always take a radiograph. Just because you use the guide, it doesn't always mean that that there's no errors in the guide or the guide wasn't was fully seated. So there is always the possibility that what if that you're drilling in a suboptimal angulation, especially in tight spaces. We don't want things to go wrong. And really do check your 3D implant position. Regarding again final position, another tip that I'm only in recent years learning is to place the implants a little bit deeper. With all of these implants, bone level implants, the manufacturers are recommending the placement to be approximately 1 millimeter below the crest, especially on the buccal aspect. From periodontal colleagues, what I've learned is implants also have a biologic width. If you don't give it to them, they will establish it themselves. For example, at your posterior mandibular areas where sometimes the mucosa is very thin, that is not 3 millimeters in biologic width. So therefore, sometimes you have to carry out just some minor osteotomy, or just to place your implant a little bit deeper into this little crater that you deliberately created, so that your total soft tissue height subsequent to placement is approximately 3 millimeters or a little bit more. That's how you get better long-term crestal bone stability. And of course, the deeper the implant placement is, in terms of then how you're going to seat your healing abutment down, you also have to take that into consideration, whether it's using some sort of bone mill or any other rotary instruments to help you to develop your prosthetic emergence profile. A couple of questions from the audience. Yes, the webinar is definitely available to rewatch at later stage. So typically these webinars are reposted up onto our SPG website approximately a week after. Another question: how do you stop cheek biting on posterior teeth? Zoe, you want to give this one a crack? Oops.
Of course, yes. So cheek biting, assessing your available space, like that case that you showed us, Ben, with the cheek has kind of expanded, or the tooth might be impinging on the available space for the cheek. So normally the angulation of that buccal contour of the cusp, if the cusps are you try to round them off, so there's a bit more space available against the opposing dentition. Also increasing that buccal palatal space, so there's no chance for the cheek, it pushes the cheek out, so it stops it from becoming entrapped between the opposing teeth. I found in cases where the relationship is more like an edge-to-edge relationship, there's more chances of that cheek biting to happen. So try to move that buccal contour a little bit more further out, so there's a bit of a buccal palatal discrepancy.
Absolutely. Yeah, the other thing I find is before we start restoring teeth, we always take records, whether it's photographic or model records, is to capture where is the patient's posterior teeth in occlusion to begin with. So let's say if are they already in buccal crossbite or something like that.
So replicate that as well.
Exactly, because often what has already worked in the patient's mouth, if we just simply replicate that, you have a much higher chance of success than to recreate it into a normal posterior buccal overjet, which then chances are then that may catch the cheek. So yeah. So let's take a quick break, ladies and gentlemen. Just a quick 5-minute intermission. Refill your bottles and refill your popcorns, and come back in 5 minutes. Welcome back, everyone. Thank you for joining us again, and welcome to the second session of Sydney Prosthodontics Group's webinar on improving surgical outcomes. We've in the first half of the session, we've covered patient assessment, local anesthetic, some implant bits and pieces, and some other medication related to the patient, whether it's bisphosphonates or anti-resorptives or anti-coagulants. So we're going to continue to build on what the previous concepts, which is now adding on to some extractions and some grafting to our learning journey. So extraction is something that I think a lot of dentists would do on a daily basis. Sometimes they're pretty simple, and you felt pretty good about yourself. Other times you would start sweating after 45 minutes, and the root fragment just feels like it's ankylosed, it's just not coming out. So Thao, what tips do you have to make it look, just because you make it look so easy? How do you do it?
Well, that comes into our next part, which is minimally invasive extractions. Okay. So I find the term atraumatic extractions, which a lot of people use, quite almost a strange word, because when you remove a tooth, you're causing trauma. So when you remove a tooth, you disrupt the vascular structures, you damage soft tissues and the associated periodontal ligament. So the idea of minimally invasive extractions is you're trying to minimize the trauma that occurs, and that allows you to have a more predictable and favorable postoperative site. So if you're looking at the image here, you want the image on the right, not the image on the left. So sometimes to have a to be conservative with the bone and tissues, you might actually prefer to go towards a surgical approach, which is almost against what we're taught when we were in dental school. But if I want to go through it really quickly with our 4 generalized principles, one of which is what Dr. Zoe would be going through. But for me, the idea is, instead of grabbing your forceps and trying to move that tooth with your, and thinking that an extraction is less traumatic than a surgery, I want you to go towards these 3 principles, really. A minimal soft tissue reflection, minimal bone removal, and then sectioning or simplification of the tooth removal, and then consider grafting and sealing. So let's quickly go towards minimal soft tissue reflection. Now, we know that the cortical blood supply comes from the periosteum. So the idea is, a lot of us want to avoid raising a flap because we don't want to disrupt the blood supply. But sometimes a flap is necessary because you want to see what you're doing. Sometimes the junction between the tooth or the root and the bone is underneath that gum. So if you're trying to blindly try to elevate the area, that's causing more trauma because you don't know where you're looking. You can't be efficient with your extraction. So the flap may be necessary for access, vision, but also for you to do your ridge augmentation. I normally, with these extractions, I normally try to avoid a relieving incision, but an envelope flap and a minimal envelope flap, which you can see in the images here, is often appropriate without compromising the extraction technique. So the next step is minimal bone removal. Now, when you associate a surgeon, you normally think, oh, we're going to pick up a big round burr and we're going to just destroy the buccal bone for the tooth to drop out. And sometimes that's the case for wisdom teeth, but for teeth that we're planning an implant, you need to consider the difference between bone removal and bone troughing. And I tried to show it in this picture here. So when you're trying to remove a tooth, the idea when we had those extraction techniques, we're taught to do a figure 8 movement for a lower molar, or the round rotational movements. The idea is we're trying to expand the socket to allow us to bring that tooth out. But sometimes if the socket, if you just look at dense bone around the tooth, really, you can really move that as much as possible. That bone is not expanding. So you're trying to create space. So the idea of the buccal trough, the bony trough, is you're creating that space. So instead of compressing the bone through that rotational movement, you're just going to create a trough, so then the tooth would come out. And I normally use sorry, I don't have an image here, but it's the Comet bone cutter, which is like a narrow, long shank burr, which is a little bit more narrow than your Fisher burr that we normally use for surgery. And that allows me to do quite a precise trough. And sometimes it's okay if I cut into the tooth as well, because it allows me that space for the tooth to come out and for the elevator to engage. So know the difference. Secondly, sectioning of teeth. Now, I can't explain to you how important this is. So sectioning the teeth, you're simplifying the procedure, because if you have a multi-rooted tooth, you're really trying to divide it into 3 roots. So then you can actually do a single root extraction one at a time. So if you look at this image, this lovely patient, unfortunately, he's losing both the 1.7 and the 1.6. Perfect root canal therapy, beautiful crowns, unfortunately cracked teeth causing significant pain, and referred by the endodontist for removal. So you look at this image, you're like, big restorations, a big post in there, root canal treated. Look at that buccal bone. There's no way I'm just going to grab some forceps and try and remove that. That's going to do significant damage. So what do? Well, firstly, I follow that principle, which is decoronate the tooth, and that allows me to deconstruct it. So because it's been root canal treated, I can actually see the GP points, the Gallagher points, and that allows me to actually find where the roots are, and it's more predictable. And then I section based on where the individual roots are. I use a contra-angle handpiece here because the positioning for a straight handpiece with your normal surgical procedures are very difficult on the upper arch. And then after that, what you don't see there is I actually also sectioned the palatal root of the 1.7. Oh, there's a picture of the burr. Yeah. So, nice. But I also, so the palatal root, that's a really thick root. So the moment I remove the buccal roots of the 1.7, the palatal root is huge. I can't put forceps on it, and you don't want to elevate on the palatal aspect. So what I did is I then just sectioned the palatal root right down the middle to then allow space for the individual fragments to go in. So I'll go into that later, but you can see that after the procedure, it's quite neat. I put some sponge sand in the area, stabilize that with some sutures, and that is, even though it's a surgical, it's actually quite minimally invasive for the patient, and the patient covered very well with very little discomfort. So going back to sectioning, when you section a multi-rooted tooth, you're simplifying the procedure. But when you section a single root, you're allowing yourself to create space. So when you section the root down the middle, you allow then that space where you sectioned for the individual fragments to kind of collapse into each other. Sometimes you need to do a little bony trough to allow that elevation. But that's the concept of sectioning, and you need to know why you're doing it. You need to visualize how the tooth's coming out. So I find that the main errors with sectioning is either the section hasn't been deep enough. Look, if you can visualize the root and you have good vision, you can actually section down the root, down the canal, without being worried about going through it. Because if you section too shallow, you're going to end up getting a J shape because it's going to be an unfavorable section, and then you still have the root to deal with. Another thing is if your section is not precise and you end up making a really large section, what happens is you have these too narrow walls, which then just break, and then you've got a little root left behind. And that's often what happens. So section needs to be precise, narrow, and deep. And then using the appropriate fulcrum points. Another thing is knowing that sometimes it's not about additional force. I'm a small person. I've never thought about, I'm going to put more force into this. It's always about reassessing the area. And again, don't be tempted, the tooth's not coming out, let's start removing a whole bunch of bone. Come back to think about why the tooth's not moving. Don't force the direction if it's against where it wants to come out. There's always a sweet spot, as I call it. And then what happens if you fracture a root? So that's always a fear of everyone, right? Yes. My rule of thumb is localize the root first. So know how much of the root and where it is. So in this case, if you fracture it, sometimes you can palpate the buccal, especially if it's broken through the buccal aspect, and you can feel where the root is. Sometimes you can't, so I often just put a perioprobe in, measure it, and then just bring it on the outside and go, this is where the root is. And there's 2 ways you can remove that root, if appropriate. One is you can actually do an apical management where you do a vestibular incision, and that's really good with managing apical pathology as well without compromising lifting a complete flap. The buccal bone, more coronal, is still intact. I've managed remove the root, manage the area, and then I put a membrane into for a guided bone regeneration and grafting, and I've sutured that area. So that's one way to do it. The other way is I try to draw it. This is my best attempt. I'm not an artist, sorry, but this is always what happens. You look down and you see that root. So the bottom left image is me trying to draw the root and the canal, and you're like, oh, what do? I can't get, nothing's really moving anymore. I can barely see what I'm doing. So you have two options in that case. One, you can section that root, and it needs a precise section, and it's better to do a palatal or lingual to buccal section, because you want the fragments to go sideways rather than pushing it out buccally or palatally. And that again requires a thin, long buccal bone cutter. Or you do a little gutter, a little trough, as I call it, because right now there's thick bone around there, you can't elevate anywhere, so it's often just troughing around it allows you to get an elevation point. And often I end up using a combination of the two. Okay, so I'm whizzing through this because we're all tired. The next technique I want to talk about, which ties in with ridge preservation that Zoe will be talking about, but I want to touch on partial extraction technique and socket shield, which is what we do quite a lot. Ben and I, we've had great success with the procedure. So we know that there are ridge alterations following tooth extractions, and it's aesthetically a concern for the patient, especially if they have that thin biotype, high smile line. And this is a great study because the image is great. It shows that with a 1 millimeter facial bone, in a thin biotype, you get a 62% reduction in that bony, that width, and often height as well. And you get that soft tissue proliferation. And whereas if it's thick, it's a reduction of 9. So in those cases, we might need to consider doing a partial extraction technique or socket shield. So essentially what the socket shield technique is, and this is just a step-by-step process, is you decoronate the tooth, if it's not decoronated already. You determine the length, because that's important. You need to know where the apex is. You want to section it, and it's really important that you're not just creating it's actually a full shield, so it's a C shape, because you want to include the papilla, because that papilla is really aesthetically important in this case. It's strange that a surgical person is saying this, but I work with prosthodontists. I know how important this is. Removal of the palatal portion, and finally you need to reduce that fragment down almost equicrestal or even below bony height, and also to create a chamfer and the chamfer is important for the restorative aspect, to the emergence profile of that tooth. And after that, you might see that in a lot of cases they do immediate implant placement, which we see a lot, but there's also an option for your delayed implant placement, which is actually a little bit more predictable, only because you allow time for the healing to take place, and when you go in the second time, you can actually reassess the shield and see, look, if the shield's a bit too high, I'm going to bring it down a little bit more. If the shield's mobile, I'm going to take it out, but it's done its job. So there's more control, I find, in that case. And the studies support that. Implant survival is high, minimal changes to marginal bone levels, and there's better pink aesthetic score. The main concern is the complication rate. So we're still figuring out if there is shield exposure, whether internal or external, how we manage that. And that can be quite difficult. So which is why sometimes the delayed implant placement is actually more, allows you to control that, that complication. And for those wondering what happens if your shield, the implant engages the shield, well, studies have shown that you still get osseointegration. So microscopically, you still see that that bone formation around the implant. And contraindications. So I'm going to quickly skip that because it ties in with my next one, which is, can the disease be controlled? If you can't control the disease, don't do this technique because the disease is going to continue afterwards. If you can't confidently eliminate the infection, you're going to compromise the implant. If you can't manage the apical pathology, again, you're going to compromise the implant. If you can't control the shape of the shield, so if you have a fracture in the remaining fragment, you can't control the shape, should you be doing a shield? And finally, if you can't remove the palatal or lingual portion. So if it's multi-rooted, if it's an oddly shaped tooth, should this be a technique you employ? So what we found is actually if there's two anterior teeth that need removal, the maintenance of the papilla has been quite significant and helpful in the aesthetics of the patient. So that's the PET technique. And I'm just going to show you management of a complication, a quick one of root and sinus and how I manage it, because we're talking about complications here. And this is for a hindsight. So unfortunately, this patient had a tooth extraction, and the dentist had done what you're meant to do, section the root. But unfortunately, as they went to elevate the mesial buccal root of the 2-6, the root went into the sinus. And of course, they were trying, the general dentist tried to retrieve it by making a minimal flap. But you can see that the concept of the simple surgical concept, which is a broad base to maintain blood supply, has not been maintained. So the tissue there is quite white, and that's because there's a bit of necrosis happening around the area. So what we did was raise the flap even further, and you can see that what had been done to try and retrieve previously. From that area, from that the osteotomy that was already done, we could actually retrieve the root, but because the defect was so large, so all your surgical skills come into play here. A large defect, you know that if you just close over that with a flap that's also already a bit avascular, you're going to get dehiscence. So a buccal fat pad was employed just for support to bring on more vasculature to the area, and you close first the buccal fat pad over the area, and then following that you put your buccal advancement flap over the top. So double closure. And then the patient recovered what? Sorry, surgeon's photography. Yes.
Fantastic. A couple of questions from the audience. Would you consider using piezo as part of your extraction process?
I find piezo very slow, but I tend to do things at a fast pace, and I find that the piezo, I've never tried piezo for extractions. I've done it for your sinus lifts, and that has been way too slow for me. And I feel like the cutting efficacy doesn't work well, and you're still cutting. You still have to elevate. So the sectioning with the bone cutter has been very useful to me.
Another question got to do with socket shield. What's the point of a socket shield if you're going to raise the labial flap? So the premise of that question is, if you raise the buccal flap, you're going to get bone recession.
Oh, okay. Well, it's kind of like an in-between. You're not raising a full flap. I think if you look carefully, I did talk about a minimal soft tissue reflection.
Well, the case that was two side by side.
Yeah.
That one, I think the full thickness flap was raised.
Oh, like so I'm just gonna.
But I think what they didn't see is. The flap was not raised at the time of socket shield.
Yes.
The flap is raised at the time of implant placement.
Yes.
Now, personally, I think that's really important. So firstly, in terms of flap design, you've noticed that I spared the papilla for both the mesial and the distal. So this is not your conventional mid-crestal incision. Secondly, the reason why I retract the full thickness flap is because you want to visually identify what is happening to the shield. Because if you don't raise the flap, often what you find is that the buccal plate is gone already. And your buccal shield is the only thing that's separating between your implant and soft tissue. So if you don't remove your shield at that point in time and graft, later on that shield can simply just dehisce and come out. And that's when you get yourself an osseointegrated implant, a good looking prosthesis, and now a massive big buccal defect, and there's nothing you can do about it. So that's why by raising a flap, while that may deem to be more aggressive, but you have full control of that site.
Yeah. I think the main difference was that was a delayed implant placement.
Yes.
So the shear was done
Yes.
with no flap was raised there. And then at the time of implant placement, which is 4 months down the track, that was what was done. Yeah.
Lots of stuff we can go into detail, but
Yes.
too little time.
Yeah.
So I think you've got 10 minutes to go.
Okay, I'll skip through it.
to go through ridge preservation, because a large part of what we do after extraction is later on is to get the site ready, whether it's for implant placement. Sometimes they just want that site to look good, even if it's for, say, a bridge or even a denture. For an anterior situation, you still don't want that big, massive buccal crater. So often ridge preservation or socket preservation at the time of extraction is very commonly used. So could you go through with us what are some of the common materials, and what perhaps is a simple protocol that you can share with us?
Sure. Thanks, Ben. So you're right. We aim to do the socket or preservation or ridge preservation just to minimize bone loss in the site. So we can place an implant or do a denture or a bridge in a more aesthetically pleasing contour of the tissues, as well as better bone quantity and quality. So as we know from research that a significant amount of bone reduction occur within the first 6 months. So about 3.8 millimeter in width, 1.24 millimeter in height after extraction. So this is a significant amount of lost bone that you're trying to preserve and that's crucial for our implant positioning as well. And that 50% of reduction in bone width and height is usually at 12 months after extraction, with the majority of that within the first 3 months post-extraction procedure. So we try to minimize that resorption, bone resorption. So what can be done to do that? Now, this series of photos will just show that initially when we do the ridge or socket preservation, there will not be a primary closure of that site. So there is a graft particles that might be exposed, and if you follow the healing process of that or presentation of that tissues, you can see even up to 8 weeks, there might be some particles of the graft that's still coming through the tissue, and only at about 10 weeks post-surgery, you get a full healing and full closure of that site. So it's a work in process, but it's okay. So even if we see these particles of the bone coming through, that is normal. We pack a lot of bone in there, and some of it will come out. So the materials, and just briefly through these materials, we won't go in details about it. We've got the collagens, the membrane, the bone graft, and the sutures. So in terms of collagens, you've got the resorbable collagens. This is a quite easy sort of material to use. They are derived from type 1 collagen. They come as a collagen plug, foams, tapes. They are resorbable. They plugged into the socket. They really fit in there nicely. They help with hemostasis, seal the socket. Very simple to use. And it's also been shown in some studies that it actually help regenerate bone following tooth loss. So it acts as a scaffold for that bone regeneration. So this is the collagen. And then we get the membranes. Membranes are coming in two forms. We've got the resorbable membranes, and they're usually made out of collagen, porcine, or non-resorbable, which we don't really use a lot for Gore-Tex in ridge preservation or extraction socket sort of reservation. So I'll talk mainly about the resorbable collagen membrane. So again, they mainly type 1 collagen, but some of them are also type 3 collagen. They can be from human sources or xenogenic sources, so for example, a bovine tendon. If you can see here in the image, they are semi-permeable. So it allows the blood cells to, the vessels to form, to come through the collagen fibrils. And it also has a chemotactic effect of the gingival fibroblast. So it gives you that barrier. So it's able to separate the soft tissue from the augmented bone, and also maintain your graft in its place. So prevent that ingrowth of the soft tissue from the site. So these resorbable collagen membranes, they have variable resorption times. Some of them resorb within a couple of weeks. Some of them might take up to 9 months. So you have to pick your membrane that you use depending on what purpose that this membrane is there to serve. For example, if you're taking a tooth out and you need and you know that the soft tissue will re-epithelialize within a couple of weeks, then usually we will go for something that has a shorter resorption time. For example, a Geischlik mucograft like a seal or membrane that will resorb within kind of 2 to 4 weeks. But if you're doing a guided bone regeneration and you need to maintain that site for a longer period of time, then you go for something that has a longer resorption time, which is about 6 to 9 months is preferred. And you've got the OsseoGuard Flex, Memlock, these kind of, and then if you want something smaller. So there's a lot of variety of membranes that you have to look into. And the way the membrane kind of resorb is just inflammatory cells biodegrade this membrane through the action of the cells themselves. So how we use this membrane, it comes sterile. You deal with it as any other sterile part of your surgery. It's measured to site, and then it covers the defect or the grafted area, and you aim for some sort of a primary closure if possible. And the other material that we use is the bone graft. As majority of us know, that there's 4 main type of bone graft material. So you've got the autogenous bone graft, which is the gold standard. You take it from another part of the person and place it in the side that you're trying to augment. So this is it has a donor site morbidity, so that some patients don't prefer to have that, but we know from literature that this is the gold standard. And then you have the allograft. So this is coming from a cadaver. So the cadaver bone that has been treated, sterilized, gone through all the antigenic procedure to remove the cells, make sure that there's no risk of reducing the risk of contamination. So this is the allograft. And then we have the xenograft, which is a kind of animal bone, for example, the BioOs, or a alloplast, which is the synthetic then bone substitute that has the calcium and the phosphate. So these bone grafts, they come in different preparation. Some of them can be cortical. You might find that a combination of 50-50 cortical cancellous, and some of them are just cancellous. They might be morcellized segments or blocks. So again, you use these graft. So for socket preservation, I think majority of the graft we use is either cancellous or cortical cancellous, pretty much. But if you got a big defect, then you might look at the cortical plates or shields there to help maintain that structural integrity of the site. So how do they bone graft work, and why do they work? And we need to look into sort of mechanism of bone growth. So there's 3 terminology that are important when we're looking at bone growth. And the first one is osteoconduction. So osteoconduction is just providing some sort of a matrix where the other cells and other part of the bone development will happen. So just a matrix. Whereas osteoinduction, then you're introducing some sort of growth factors, because there are some mesenchymal cells that are not differentiated yet, and we need the growth factors to help these cells to differentiate to become an osteoblastic cells. So there's the property of osteoinduction is quite important. And then we have where there's osteogenesis, where whatever bone you've taken, it's already got the cells, the osteoblast, periosteal cells, and they will directly produce bone. So for when we have some sort of a bone defect and we're looking at the bone growth, we can see here that bone formation, new bone formation in that sort of created defect will rely on the osteogenic progenitor cells that will come from your pre-existing bone, so the native bone in the site, the surrounding walls that will have the bone cells. And then we fill that site with bone graft material, so that will provide us with the matrix where these cells can actually attach and adhere to these grafted material, and then start to differentiate and generate a new bone. And then the other important factor that we have is the growth factors. So we've got platelets that are produced from the blood vessels in the area. So these platelets would generate all the growth factors that we need to help that differentiation process of these cells to start to become an osteogenic progenitor or osteoplastic cells, which will be forming cells. And then the other most important factor that will need to happen as well is we need a good blood supply. So neoangiogenesis is crucial for bone growth and for filling in this gap in the created defect that needs to happen for that bone formation to succeed. So if you think about all bone grafting materials, so from allograft, autogenous bone, cancellous and allograft, and alloplast, so these, all of them, if you think of them, they all have osteoconduction properties. So they all provide us the matrix where cells will attach to. Now, what distinguishes the autograft is actually got some cells as well. So you've got the osteogenesis potential of this bone, which doesn't exist in any other form of the bone augmentation material. And then we have osteoinduction, where there is some growth factors. So autogenous bone, we generate some, it has an osteoinductive properties, and allograft as well. Especially if it's a demineralized form of freeze-dried bone allograft. It's been shown that it has quite a large osteoinductive potential there. So this will help stimulate. So in your choosing a bone grafting material for your day-to-day use, I suppose all of them will work in one way or another. But if you have a larger defect, maybe choosing something that may be an allograft or autogenous bone that will help have that osteoinduction as well as osteoconduction, so improving your chances of generating a better bone. But whatever works in your hand, I suppose, at the end of the day, that's what you should stick with. Okay. So if I'd like to share this case with you, so we've got this patient, lovely patient. He's a smoker. He's got some sort of localized periodontal bone loss at the one side, so that he came in with a tooth in his hand. Is that so my tooth just fell out of my mouth? Can you do something to replace it? And you can see there's a lot of vertical soft tissue deficiency, vertical bone loss, as well as horizontal ridge deficiency at that side. So as you do with any patient seeking implant treatment, assessing the bone, remaining bone, and you can see there's a significant loss in height and width for us to predictably place an implant. So that we discuss grafting and kind of ridge augmentation procedure, and following a successful ridge augmentation. I think I've used an allograft in this case. I think it was an Orovance. And some sort of a longer resorbable membrane, collagen membrane. We have generated enough bone for us to be able to place an implant and restore that implant for the patient. So in terms of looking at your protocol, what we do in the practice predictably. So first of all, once taking out the tooth atraumatically, we can have a look at the socket and inspect, is there any dehiscences, any fenestration, and making sure that there's no infection remaining in the site or soft tissue remnant. Assess the buccal wall thickness. Then you can make a decision about what the steps to do next. We've done a CBCT scan. You can measure, assess from the scan whether there is any buccal bone dehiscences or defect before you take the tooth out, and then add the extraction, so you can predictably plan with the patient what's going to happen at that procedure. Taking the tooth out, ensuring that the site is clean, there's a nice healthy bleeding bone underneath, there's no remaining granulation tissue in there, and we've got an intact buccal, all bony walls are intact. So for this case like this, it's a very easy just place even a biocollagen or anything like that you like in bone grafting material, and then seal it with a spongiospan, and then some sutures, and that's done for this case. So you don't really need a membrane in this situation because you've got the bony wall all intact. But if you have a buccal bone defect, as you can see in this patient with one side has a large infection that has perforated through a draining sinus on the buccal wall. So looking at the CBCT scan, there's a huge buccal wall defect in there. So the whole actually buccal wall is gone. Following the extraction, and without raising a flap, so you don't really need to raise a flap there, you can take the tooth out, curate the site, make sure that you've got nice, healthy bone around it, and then use a membrane. So reflection of the soft tissue away from the bone on the inner, so they're raising kind of an inner flap to be able to tuck in the membrane, and typically extend that membrane about 3 millimeters beyond the bone margin to be able to lock it in place. So putting the membrane inside that flap on the outer contour of the bone, but under the soft tissue, and then pack it with your bone grafting material, and again with a spongiospan at the end. And some sutures just to hold it in place. And with time, as we've seen in the first, in the series of healing photos, this will cover up with bisecondary intention and you get full healing. So what do we need after we've done the grafting? We make sure that you give the patient good instructions of meticulous oral hygiene, using some antiseptic mouthwash like a chlorhexidine 2 to 3 times a day. Perhaps put them on some antibiotics, especially if there was some sort of an infection at the site. And if they're wearing a denture, ensuring that there is enough clearance between the denture fitting surface and the graft to allow for at least 1 millimeter, just in case if there is any expansion, swelling, and to prevent any rubbing or irritation of the site between the denture and the area that we grafted.
Fantastic. Thank you, Zoe. Our audience really love this topic. We have so many questions. So if I may just summarize into the key question groups. The first group is asking, why don't you use a non-resorbable membrane? Because everything so far we're using are resorbable material.
Yes.
So why don't we use a non-resorbable membrane?
Non-resorbable membrane, it is more technique sensitive. You really need to look into, because of the rigidity of the membrane, you need to look into soft tissue closure, full soft tissue closure, to ensure that there is no infection or irritation of the tissue and opening of the flap. So I find in my hands a resorbable membrane is much easier to cover. It's more forgiving. Even if we don't get a full primary closure, we won't get the full resorbable potential of the membrane. Like if it says 6 to 9 months, it may not last if it's exposed. No. It will resorb much quicker. But again, even if it's disintegrate a lot quicker, it's not going to impact our procedure as much.
And then a follow-up question on that is, one of our audience have used a titanium reinforced membrane. There was a bone augmentation procedure. We don't know whether there's an implant underneath it or not. But unfortunately, there has been, only on the crestal region, there is wound dehiscence. Everywhere else seems to be okay, but just the crestal side. Now, we don't know how big it is. We don't know a lot of other information, but according to the audience, that there's no infection.
Okay.
So what would you do in that situation? Would you give L8 and take the whole thing out and literally start from scratch? Or would you use a more conservative approach, given that there's no infection?
Given there's no infection, no pain, asymptomatic, then I'm assuming that there is no issues with that site. Even if there's a soft tissue dehiscence, you will allow the soft tissue to recover on its own and heal. So instruct the patient to avoid eating anything hard on that side, so softer diet, using some antimicrobial mouthwashes. If you're concerned with antibiotics, I'm not sure, but usually it might apply that as well. and a review, so regular reviews. So might see the patient in a couple of weeks, ensuring that there's no, and if anything changes in the symptoms, to inform the patient to contact us as soon as possible, not to leave it like that. So the worst thing that will happen is that bone augmentation will not work if there is an infection that develops.
I will see that patient every couple of days, just to see that is that dehiscence getting smaller.
Yeah.
And if it is, and it's still asymptomatic, there doesn't seem to be any pus separation, I think keep on going. We're on the right track. But if anything that's looking like it's turning Thao's, I would straight away get in there, just remove the whole thing. In terms of the grafting material, another interesting question is, would you consider just using your xenograft only? So, for example, your Bios collagen only, or would you do something a bit more fancy and start to collect a little bit of harvest, a bit of autogenous bone, and do a little mixture? I assume this is for ridge preservation, not for simultaneous guided bone regeneration during implant placement, since that's the topic that we're on.
Yeah. Well, I would consider if it's one of these sites where you've got a full bony wall, even if there's a buccal wall defect, there's no harm of using that. So it is acting as a osteo matrix. So you'll get your own cells, and that bone graft. Sometimes if you the main thing is not to pack it too densely into the socket. Otherwise, you'll come back. Otherwise, you'll exactly. Otherwise, you'll come back and there's the particles that haven't really changed or transformed into a healthy, vital bone. So we know that there's a lot of non-vital bone that's remaining, particles that will remain at the site anyway, regardless of any bone grafting material that you use.
Absolutely. Yeah. Thank you so much for covering this topic. And to bring us home, Thao, because a lot of audience do carry out wisdom teeth extractions, some even quite advanced wisdom teeth extraction. I know you spent years doing this even before you started your oral surgery program. Once again, what tips do you have for us tonight?
This is going to be the quickest oral surgery rundown ever. To use training into 10 minutes or less. Let's go for it.
Yeah.
So for me, the principles are, we can learn about in books that you're going to remove bone, you're going to section. But the issue is when things don't go right. So I'm really going to quickly go towards some tips and really come out with simple messages for everyone rather than doing a huge thing about lots of different wisdom teeth. So the principles for assessment of wisdom teeth: age and the stage of root development is really important. For me, the golden age number is 25. Anything over 25, if you're getting to a patient in their 30s, 40s, you know that the surgery will probably be a bit more difficult. The recovery is going to take a little bit longer. The patient will need more time off work. It complicates their life a bit more. Take that into a consideration. The stage of root development is important. I'll show you a bit later, but you don't want to go in too early because you're going to have issues, but you don't want to go in too late. You want that fine time. And sometimes it means that when a patient is referred to me, I actually go, maybe just wait a year because it will make your recovery and your surgery a little bit better. There's nothing wrong in that case. It's not going to affect the rest of your dentition. And that's how I talk to patients and I monitor them. Secondly, access and vision. You need to see what you're doing. You need good vision, you need good lighting. That's really important. Elevation point. I'll explain to you why distal angular impactions are so difficult, and the main issue is where the elevation point is. Simplifying the procedure, so sectioning the teeth, that's important. Knowing where the tooth wants to come out. You can't force a root or a tooth to come out where it doesn't want to come out. It means you're going to put more force into it, you're going to damage something. And finally, if there's no space for the tooth to come out, you're kidding yourself to think that it will come out. If you need to create that space. So let's quickly go to vision. You need to have I use a Minnesota retractor, and you can see, just to look at the 2.8 that's impacted there, look at that vision. It allows you to protect the tissues, allows you to access, because what I find is when we're so focused on the surgical site, and we don't have adequate retraction, you actually damage the lip. And I've seen some horrific injuries that have been referred in, burns past the vermilion border, purely to the fact that there hasn't been retraction because we're so focused on the surgical site. So my first tip, get a Minnesota retractor. Some people use a rake, but I find that the Minnesota is more versatile. Secondly, why is the stage of root development really important? I get a lot of these referrals with the crowns of the roots of the wisdom teeth, and asking me to remove the wisdom teeth, which is fine. My only factor is I call them roly-polies, because firstly I have to locate them. The child's normally younger. I have to locate them by removing a lot of bone, and because the root is not there, it hasn't been developed yet, what happens is the crown just starts spinning. So I'm trying to section and it's just spinning around, and I'm trying to follow and then I think to myself, you know what, if I just waited maybe a year or two, and then with the roots starting to develop, it would have locked the tooth in. I could section a little bit more. I wouldn't have to remove as much bone over the lying surface of the tooth. I reduce that complication just by waiting a little bit longer, to be patient. And I think that's my rule of thumb is during root development, that golden stage in the beginning of root development and just before root development, that's great. There's that leeway space for you to remove the tooth, and also means that the patient's a little bit younger, so they recover a little bit better. So quickly showing you, this patient was referred, perfect timing. They only wanted the lower wisdom teeth removed. The upper 1/8 wasn't causing issue. And you can see the roots in the final stages. So it's open apex, the far away from the canal. And so you can imagine all I did was little envelope flap, elevated the teeth out. That's just a bit of tissue that often comes with it. But easy, straightforward, uncomplicated. Patient recovered really well, minimal swelling, minimal discomfort. This is just a case just to show that sometimes because of the root development, it actually comes out a little bit better than planned. So here, although you can't see it clearly, that the tooth is just the lower wisdom teeth are just in the final stages of root development. But when I was looking at this, when I initially planned, I'm like, okay, I'm going to section the root on the 3/8. I'm going to do it obliquely to create some space for me to take the tooth out, and on the right, it doesn't look like there's much room there, so I'm going to have to probably section the crown, and then also decoronate and then section the crown. The upper 8, the patient was happy to leave because it wasn't causing her any issues. But what happens is this: the 3/8 actually just quite elevated out quite nicely because it's still undergoing root development. The bone's a lot softer, and on the 4/8, all I really need to do was decoronate, and then the crown and the roots came out quite nicely. So it just shows you that final stage of root development really great. Okay, so that's my first point. My next point, which is root development. Secondly, is earlier management important? Well, yes, that's because the NICE guidelines in the UK was introduced in 2000. They recommended against the prophylactic removal of wisdom teeth. They're saying you were removing too much. Like, only remove it if there's a problem. Now, it's been 24 years now, but there's been studies to show the consequences of the NICE guidelines. And what happened is people they were getting less wisdom teeth removed when they're young, but they were coming in later on in their 30s and 40s with removal of the wisdom teeth, often with the 7 later on. So these patients are actually presenting later on. So my rule of thumb is even if the patient has good oral hygiene, you're like, oh, they can maintain it. You don't know what they're going to be like later on. And if they're going to go on bisphosphonate treatment, if they're going to have chemotherapy, if life changes and they can't take care of their teeth, they're going to have to get their teeth removed later on. So if you think it's a problem, deal with it. So in this case, this lovely gentleman who's 52 years old had a horizontally impacted 4/8 for a long time, and he was told, oh, you know, for his dentition, pretty good for that age, and he was told to leave it. Unfortunately, now he's got a periodontal defect associated with the 7 and significant food impaction. He actually had facial swelling, which was managed first before I removed the tooth. So when I went, but he has good access. You can see, even with the mirror, I can see what I'm doing, and the tooth's actually a little bit more buccal than it appears. So when I planned it, I said, look, I'm going to raise a flap, decoronate, and because of that bone loss, it's actually been helpful with it. It has space. And so, but I still needed to divide the crown because it's still a big crown. And really important to show that I've actually removed the granulation tissue. If you leave that granulation tissue there, they're more prone to infection. And I also removed the top tooth, the 2-8, because you can see it's all already over-erupted there. So earlier, if you predict a problem, deal with it earlier. Do surgical plans always go to plan? No. The reason why it's hard for me to give advice for people sometimes is sometimes I can tell them this is going to happen, but just need to understand that you need to be able to deviate and problem solve at the time. So in this case, I looked at the tooth. The patient was 21, young. I go, ooh, the top 8s are going to give me a few problems here, but the lower 8s might be quite easy. So my plan was section, maybe elevate out the 2-8. So straightforward plan. This is straight out of a textbook, really. This is how we plan. And what happened? Well, actually, the upper 8s just flicked out. I needed to remove a little bit of bone on the 1-8, but the access was quite difficult. The access was quite good, and there was an oral intercommunication, but I actually managed it because they're young, managed it well. The bottom, the 3-8, actually just sectioned the tooth in half, and then it came out quite quickly. And strangely, the 4-8, you can imagine what happened was that segment that is below the 7 gets trapped. So everything's mobile, but it's stuck there. So I actually had to kind of, I kept sectioning the crown, just to make it smaller and mobilize the area. So I was creating space. So there's nothing wrong if you need to section more. If you don't, what the tempting thing is, it's mobile, so I'm just going to keep playing around with it, and it's spinning around and you're spending time. No, just do yourself a favor, cut it safely and remove it nicely. Yeah. And then quickly, this is another case where the patient was young, 18 years old, undergoing root development. And I was like, this is probably going to be straightforward. So I'm just going to section there and there, and she was we just removed the upper 8s. And I was working that lower 8 for some time because it was, if you look at it, it was actually like multiple roots in place. And I could tell the mobility wasn't happening straight away. And for an 18-year-old, it should happen pretty quickly. Wow. So I predicted I'm going to have to section these roots. And so instead of really trying to elevate it without more force, I went, okay, I'm going to decoronate, section, and section. But the left side came out as planned, but there was an extra root that wasn't, that it looks like there's 2 roots, but there was actually 3. So, and finally, why are distal angular impactions, why are they difficult? Well, purely because there's no space for you to put your elevator. Normally you want to elevate it, in that point you want to elevate it distally. The tooth wants to go distal. So distal, you got your mandible, the ramus, and then there's no space. If you fracture the crown off, how are you going to elevate it? Because the tooth is so up close to 7, you can't do a bony trough for your elevator to fit. You're going to actually cut into the 7. So, and they're not all the same. So this is a nice case of this is what you would consider distal angular. But what do you notice? There is space between the 7 and the 8. And so with this case, amazing photos again, apologies. Flap, bone removal, you decoronate, and then you remove the top portion of the crown, and then it allows you to see, and you section the 2 roots, remove the mesial root first, because that's where you elevate initially from, and now there's space for you to bring your distal root, and then closure. So that was like a distal angular tooth. And this one, there is space distally because of the bone loss that has occurred. So all I did was I mobilized it first, and I noticed it did mobilize, so I'm happy to decoronate and then curve the root into the space that was created by the infection. And finally, this is not a case. This was a case referred in. This was one that it was erupted. So unfortunately, forceps were placed on this tooth, and you can see there's actually very little space between the 7 and the 8. And what's happened? this is what's happened when he was referred in. So the crown, there was no mobility, the crown broke off, and by the time it was referred in, you can see that bone formation already happening. But because it's been done, the patient preferred to leave it because it had closed over already. And that goes to my next point, coronectomy. That was not a planned coronectomy, but there is a study by Rood in 1990. A lot of people know about this study, and it tells you about the signs that are associated with high risk of inferior alveolar nerve injury. And even though there are lots of different radiographic signs, the main three is one, diversion of the canal, and that's on the bottom left, and then the interruption of the white lines of the canal and darkening of the roots. So those three are associated with a high risk of inferior alveolar nerve injury. So in these cases, we should consider if coronectomy is appropriate, considering the impact of paresthesia. Even if it's low, if it's 1 in 100, your patient can still be the 1 out of 100. And if it affects their quality of life, you need to think that you need to be able to offer appropriate options. So this is just showing you how the recovery of coronectomy occurs. So this is a tooth, obvious close association with the IAN. Coronectomy occurred, and that was immediately post-op. And then 12 months, you see that bony healing that takes place. And 6 years down the track, complete bony, it's entombed in the bone and has not had any issues. So this is a case that I did. Patient was referred mostly because of the 4-8. It's a deep, and the 1-8, but it was a deep periodontal pocketing, but he's obviously got that narrowing and diversion of the canal. And this patient is 39 years old. That tooth is not going to move. And he's very concerned about the risk of nerve injury. He's done his research. That's why he avoided surgery for so long. So I did the coronectomy for him, and it worked well. But often with the coronectomy, the crown is still large, so I end up dividing the crown as well to bring the tooth out. And he was happy with the result. And essentially the complication rate for coronectomy is very low. So the study by Bacelos in 2019 looked at reoperation rate and looked at it was 5%, and that could mean it migrated, and it migrated away from the nerve. So considering the impact of nerve injury for a patient, it should be always be given as an option to the patient.
You always make complicated things look easy, Thao. Couple of questions for you.
Yes.
It's got to do with post-op management.
Yes.
I think you may even have a slide.
Yes, coming up
on that. Perhaps you could include as a part of your post-op management what usually analgesics or antibiotics do you include in?
Sure. So post-operative begins at the beginning.
Yes.
So you establish rapport and understand the goals for the patient to allow you to formulate a treatment plan. There needs to be thorough explanation. No matter how I look at a procedure and I go, that's actually going to be quite a straightforward procedure, I tell the patient, you're going to look like a chipmunk, you're going to be swollen, you're going to be bruised. You need to be able to control that expectation for the patient.
Really lower it.
Really lower it, because you don't know how they're going to expect. And all the issues I've ever had are from the ones where I've told them you're going to be fine. Whereas the ones where they look, like this, they're like, great job, great job. And so I think it's important that we really bring that expectation for the patient. But as we mentioned, preemptive analgesia. Look, the Cochrane review for post-op management still shows that ibuprofen with paracetamol together at 400 milligrams of ibuprofen and 1,000 milligrams of paracetamol is superior to any other post-operative medication. And it's still that way. And the idea is it's not just about take it when you need it. It's preemptive, on the clock. So the patient has a timer, they're taking it on the clock. The only deviation is if they can't take NSAIDs. So then you need to consider additional, so often Panadine Forte. But I would actually I would prefer actually endone over Panadine Forte sometimes. Really? Only because Panadine Forte is unpredictable. But I would control endone of how much they take. And there's obviously new medications such as Palexia. But if the patient can take NSAIDs do use the simple first, and there are other alternatives which include caffeine, or tramadol, and I would always ask what has helped them before first. And if they haven't used pain medication, then go to your Nurofen Panadol. Post-operative antibiotics, look, antibiotic stewardship is very important, but you need to understand the patient, their recovery. If I'm talking about 4 wisdom teeth, they can't brush their teeth well. Nutrition's going to be affected. They're not going to feel well. So I would prescribe antibiotics. And that would be a shorter course is actually okay. 3 days has been shown to be as efficacious as 5 days, and it increases compliance because people will take it for 3 days, but 5 days they are less likely to take it. And amoxil 500 milligrams 3 times a day is the standard unless they have an allergy. There's no point going straight to augmentin duo or anything like that. Unless they've recently used it because of a facial infection.
Do you find antibiotics more effective than, say, chlorhexidine mouthwashes?
It's hard to say because the studies they look at it as numbers needed to treat.
Right.
And with a lot of the studies, antibiotics, it's hard to know because you don't know which patients they're choosing, and most of the patients are healthy. So obviously the numbers needed to treat are higher because if they're healthy, they're unlikely to need
it anyway.
Yeah, so sometimes it's a good combination between the two. But mouthwash is quite good for prevention of dry socket. That's a study which is shown. And finally, there are a role for corticosteroids to bring down that swelling for that patient, especially if they need to go back to work. And it's good if they can't take NSAIDs, then maybe supplement your paracetamol with dexamethasone. And the study suggests that pre-operative dexamethasone is actually the efficacy is higher than post-operative dex. So plan ahead.
Absolutely.
Yes.
Yeah, I always find out by the time when the patient is massive.
It's hard to bring it down.
Yeah, and then you give dexamethasone, it takes a long time for that to go down. So it's much better to give them beforehand.
Yeah.
Just before everyone logs off tonight, just a quick remember regarding your CPD certificate. Please fill out the form where the CPD section is on the bottom of your screen if you want a CPD certificate. And just perhaps just a last question for the panel regarding this is a combining extraction and chemotherapy. So this is a patient had a history of chemotherapy. Now we don't know how long ago it was. It was a very long time ago. I don't think this is of any relevance. But otherwise, a tooth is already highly mobile. Now, do you have any concerns with that? Or maybe let's make it a little bit more interesting. Maybe let's assume that the chemotherapy was just ceased last week.
I think with chemotherapy, there's so many different types of chemotherapy right now. And we need to understand what the concern with chemotherapy is. One is their immune suppressed state. Secondly, their coagulation might be an issue. And then the patient's overall management can be more difficult. They're uncomfortable. So I think in that case, it's more important to liaise with their oncologist to see, because if you've got a mobile tooth, but it's been mobile for some time, why suddenly is it an issue?
Right.
But if there's infection, then the immune compromised state is going to make it worse.
Absolutely.
And they risk having a facial swelling. So it's a balance between what's the risk to the patient, and it's all about liaising with their oncologist. And you often need a blood screen as well, because you don't want to take a tooth and it bleeds out because their platelets is low. And to see when it is safe to do so, because if there are issues with coagulation, the oncologist can help you with that. They can also recommend appropriate antibiotics if that works well with their regime. So I think the important is the discussion and why you're doing it.
Absolutely. Thank you so much, ladies and gentlemen, for joining us, and we'll be able to log off in a moment. The slide you see on screen is about prevention, and I think we've really sort of reiterated that point quite a fair bit this evening. Just before we log off, Zoe, any final summary, any final remarks for our audience?
I think definitely accurate assessment of medical history, managing patient risks, and minimizing potential problems from occurring. So assessing their periodontal, kind of managing their caries and things like that. Simple things that we can do.
Can we safely treat that patient, basically? Yeah, absolutely. Thao?
Be prepared for the unpredictable. Yes.
Vice versa.
I'll make it simple. Yes.
Plan B and C.
Yes.
Okay.
Absolutely. Ultimately, I think rule number one in medicine or dentistry is to do no harm. So during your whole point of assessing is to make sure that we're providing these treatments as safe as possible for the patient, and to develop strategies to helping to negate some of those potential risk factors and come up with a good solid plan of how to minimize it, how to resolve it. Good communication with the patient, and last but not the least, select the patient that you think that you can control, you can manage if something goes wrong. So once again, ladies and gentlemen, I just want to say thank you so much for joining us this evening. Thank you so much for referring your patients and trusting us to look after them. If there's any concerns, any issues, please don't hesitate to contact the practice or me directly. On behalf of the entire panel, Zoe, Thao, thank you for joining us.
Thank you.
Thank you.
Thank you.
Good night. Take care.
Bye.
Bye.